That was the clause that removed the requirement for the AGM to approve the financial statements.
That is a proposed change, yes.
So that remains standing.
Yes. The proposal from the board was to change the wording from approve to receive for information.
I don't know, with the permission of the board, or with the chair, if I may now pose another question.
Go ahead, Dr. Geller.
So I do think the AGM provides critical oversight, and this is really the only opportunity that the members have to ensure that their membership money is being used the way they want it to be used. This is their opportunity.
Dr. Geller, I'm sorry, can you propose a motion then and speak to the motion?
Well, if I propose a motion and then speak to the motion, it closes debate.
No, it doesn't.
It does not.
I can only speak to it once.
You must propose your motion, you must get a seconder, and then you may speak to it. You may speak to it twice.
So I'm not aware that in Robert's Rules of Order, in order to speak, that I need to have a motion before I can address the AGM. Can someone show me the clause that says I must have a motion before I can address the AGM?
Dr. Geller, it's Kishore here. So we loosen the rules of the assembly to allow asking questions of invited guests and our consultant. In this case, you want to propose a motion. So please give us the wording of the motion. We'll find a seconder, and then you will have the privilege of speaking first to that motion, but that will not close discussion, and you can speak again to it.
Not sure that you have the right to limit a member's to address the AGM. Nobody has the power to limit a member addressing the AGM.
Okay, in that case,
This is
I'm
the AGM, not the RA.
sure. I'm just offering the president, who is chairing this meeting, advice, and so my word is not final. So I suppose the president could either choose to rule on that, or we could get advice from SMA staff.
Yeah, being a virtual meeting and we have a limited time to go through this is important matters. I will just get advice from other staff for a minute as well. So please, thank you for your patience. Yeah. Okay. I think we will proceed, and then Dr. Geller, go ahead. So with your comments.
Thank you. I mean, as I was saying, the financial statements coming to the AGM for approval is the only chance the membership has to actually review the financial operations of the organization and provide oversight to ensure that their money is being spent the way they intend it to be spent, that there aren't, and that their opportunity to ask the finance committee, the CEO, and the board for clarifications about how the money is or is not being spent and where overruns come from. If they're merely receiving it for information, the ability to ask those questions is severely hampered. And the membership then is no longer has the ability to provide the oversight except through the RA, which you may argue could do that, except the RA elects the board, the RA selects the finance committee, the RA selects the auditor, and so then the RA controls everything around the finances and there is no outside agency that could then question with any authority or oversight how the RA is functioning financially. Insofar as that's the case, I would say that to merely include this as part of housekeeping or general principles is a significant violation of trust. the flippant comment about financials are what they are it borders on insulting, and I would like a response to that before I make a motion.
Okay. We have another question, Dr. Shannon.
Hi, Brian. I am the, soon to be retiring chair of the Finance Committee, and it's not actually flippant. As Brian said, you have to accept audited statements or receive them from information, because you can't change statements retroactively. We can't go back and change the finances. We can question them, we can ask for input, we can change the budget, but you can't change audited statements that have been done. That's what Brian said in his comments. So you receive for information, but that doesn't negate making comments or changes going forward.
Thank you for your comments. I think there's just one other thing is the RA is being elected from the membership. They have terms and they have accountability in that way. And so out of the whole province, the RA has a diverse interests and oversight. So I'm also feeling that the RA is the body that does have the ability to oversee all of this. They have access to the statements on the website, and so that is the primary responsible and accountable body to oversee the board and the finance committee. So there's one more question.
We have another hand raised from Dr. Stoneham.
Dr. Stoneham, please go ahead.
Oh, and can you hear me?
Yes, we can.
Yeah, actually, I believe that Dr. Shannon just raised the point that the statements are received for information. You can't change them. You can't approve them. They are just received for information. So I was just supporting essentially exactly what Dr. Shannon said.
Thank you. In the interest of time, I think we need to wrap up. And there's still the question about the procedural aspect of this. So okay. Are there any other comments we still have to figure out some of the...
Who's trying to make a comment?
Do you have somebody else for the question? Nothing showing up for us. We have one question.
We have a question now from Dr. Thorpe.
Dr. Thorpe?
I was just going to say Brian had his hand up, Brian Sharfstein.
Oh, Brian, go ahead.
Well, I would certainly concur with many of the points that Brian Geller has made in regard to the ability of the AGM to look into the affairs of the association. The resolution, as you see where it says information, is just a clarified process. But in fact, the AGM is given authority over bylaws, so they have to see bylaws and approve them, and they have to be presented with the financial statement. So that doesn't change the opportunity that the AGM will have to review and then make comment. And clause A says they can make any recommendations they like. So I would, in an effort to reassure Brian Geller that this would not diminish the ability the AGM has. It reinforces they will see the financial statements, but they'll receive them for information because you can't amend a retrospective financial summary.
Well, that may be. There's a difference between receiving for information and approving. I think that's probably what we're debating right now. And I think that the level of oversight required to approve something is higher, and that would then imply that your ability to delve into it and question it is also higher. You could receive them and not approve them because you find that there's evidence of fraud or whatever. And so it is not a fine distinction. And I think it's wonderful that the organization until to date has always benefited from the fact that the AGM has received and approved as if it was for information. But I do think it's a very important oversight role. As I pointed out, the RA then becomes very monopolistic in its power. It appoints the finance committee, it appoints the auditors, it appoints the board, it approves the budget. Everything then depends on the RA, and nobody has the power to say to the RA in a forceful way, the way you're doing the finances is not acceptable. Clause A may very well provide some of that, but then you could then argue that by separating out Clause B for distinct consideration, then removes it from the oversight of Clause A. I mean, I think, and those are exactly the kinds of things that I'm saying, is that it shouldn't just, these sort of shouldn't just be considered quickly, and they should be considered in a more in-depth way. And so, if I may, that would be the motion I would make, that this clause be removed from consideration at the AGM and fully explored by the Governance Review Committee, with a report back to the AGM and the RA before a bylaw amendment affecting this is voted on. That clause would be 16.4.1b.
All right. Ivan, did you guys get the motion that was proposed? Ivan? Did you guys get the motion proposed? Yeah.
I'm wondering if you could mute me, please. I need to return a call.
We need the motion as well, though.
I believe there may be another motion coming from the floor. We do. Okay.
So,
What will this motion be? Does it have to do with tabling or postponing the current discussion? In that case, that motion would take precedence.
okay. So there's another motion speaking to the current point. So a motion from the floor presented by Dr. Epp. Be it resolved that a special meeting of the membership be convened as per the SMA bylaws to finalize the AGM discussion begun today. Moved by Dr. Epp and seconded by Dr. Litwin. Dr. Epp.
Hi, I will speak to this friendly motion. Clearly, there's a lot of good discussion, and unfortunately, we are in a virtual platform, which makes communication difficult sometimes, and there are time limitations on the meeting today. So in the interest of giving this the fulsome discussion that it obviously needs, and the fact that the verification of the vote needs to be done, and that can't be done immediately, and that this deserves, the full attention of the membership, I would propose that we defer this to a special meeting that will be called in the future, so that we can finalize the discussion around these governance issues.
Thank you, Dr. Epp. Dr. Litwin, do you want to speak to it as well? Any questions? There are no questions. There is a question, sorry. Pardon me.
We have a hand raised from Dr. Pillay.
Dr. Pillay.
Thank you, Mr. President. I like the motion. I like deferring the discussion, but I think Dr. Geller has just got one point there. And if we're at the point where we can just vote on this, we get it over and done with, instead of having another whole day to discuss this. I mean, there are other points which can be referred back to the governance committee for review, but I think he just has one point. If it's just one point more, I would say that we should not be postponing this to another meeting. That's my opinion. Thank you.
Thank you, Dr. Pillay. I think there are other considerations as well. We're not through the AGM topics that need to be discussed, and there's a time limit in terms of what we can do. There's another question.
We have a hand raised from Dr. Burwell.
Dr. Burwell.
Hi, I just wanted to also go back and sort of say that I think that because the vote was so close on Brian's original motion, and if the outcome of that vote were to change on scrutiny of who was voting, it could change the discussion a lot. So I think there's more at stake than just this this one thing that we're discussing now. And I sort of agree with Dr. Epp. Thank you.
Thank you. Any more discussion?
We have one more hand raised from Dr. Geller.
Thank you. I just would like to ask Dr. Epp to clarify whether or not that would include the motions that were previously, or the amendments that were previously discussed and motions made on, or if it's just, or if those would be excluded.
Thank you, Dr. Epp.
No, my intention is not to exclude things, but the vote needs to be verified. And as Dr. Burwell just mentioned, that could change in upcoming discussions. So, you know, we need the facts to be able to carry this discussion forward. And I think that is the spirit of why I'm doing this, so that we can all participate fully informed.
Thank you for that answer, Dr. Epp. I would support the motion.
Okay. Are there no further questions? There's another question.
We have a hand raised from Dr. Kalra.
Kalra?
Can you hear me?
Now we can.
Okay, thank you, Mr. Chair. I think I will support this motion, the last motion by Dr. Epp, because it will give us a clarity, it will give us a time to think about it, and also many questions which are raised by Dr. Gallagher can be answered at that time. Thank you.
Thank you. I would then call the question, Resolution 9 be resolved that the special meeting of the membership be convened as per SMA bylaws to finalize the AGM discussion begun today. Moved by Dr. Epp and seconded by Dr. Litwin. I'm sorry, there's yet another question, so can we have the speaker, please?
We have a hand raised from Dr. Hayton.
Dr. Hayton.
Can you hear me?
Can.
Yeah, sorry to prolong this. I guess I just wanted, I wasn't clear. I thought it would be my understanding that if the initial vote that was carried out with respect to Dr. Geller's initial motion turns out to be against the motion, that would stand rather than be revisited. And I wasn't clear on that. Whereas if it's voted in favor of his motion, then of course that's a different matter altogether if the initial vote is reversed. But could that be confirmed one way or the other, please? Thanks.
This motion would agree with what you said, Dr. Hayton. That yes, it needs to be confirmed, and once it's confirmed, if the motion is carried, then it's carried, and if it's denied, then it's denied. But that doesn't preclude the need for a more fulsome discussion about this entire topic, I think. And the verification can't happen in the immediate moments of this meeting, unfortunately.
Okay, there's another question.
Dr. Geller.
Yeah, no, thank you. So I wasn't sure who was just speaking, but it was my understanding from Dr. Epp's answer that this motion would include the previous motion, whether it was defeated or carried. That was my understanding from Dr. Epp's clarification.
Yeah, it has to be verified, but discussion can still occur at a future meeting.
Are you clear on that, Dr. Geller? That it need to be verified in order to, and then it will come back to the discussion at this special meeting.
So regardless of the result of the vote on my motion, that will be discussed at the special meeting.
So if it's been carried by the by the numbers that we have today, verified numbers, then it will stand.
Yeah, the motion will stand, but the topic can be discussed.
But the topic can be discussed.
Okay, thank you.
Is there another question? All questions done. Thank you. Can we vote? Voting starts now. You have 20 seconds.
Because of the time constraints, that we propose a consideration of the special committee on governance's report be deferred to coincide with the special meeting of the
Thank you. Polling has ended and this motion is carried. I just want to, because of the time factor here today, we will not be able to get through the whole agenda, and so this will be discussed at a special board meeting, and please watch out for further information in the next week or two regarding this. This then concludes our 2022 annual general meeting, and this meeting is now adjourned. Thank you all for joining us and for your input.
Back to me. Welcome back to the RA. I'll just take a moment to ask, because of that most recent motion that was passed, I think we're moving on to resolutions. We'll just hear a word from Bonnie Brossart.
Yeah, thank you. And first of all, I want to thank everyone for the
I'll invite her up to the stage here.
Again, let me start with a very heartfelt thanks to the debate and dialogue that's happened over the last hour and a bit. There's no question, as Dr. Sharfstein said, governance is really the foundation to our organization, and it's what makes us strong in terms of our efforts. So the next item on the agenda was the Special Committee on Governance report. And you know from Dr. Sharfstein's presentation a number of minutes ago, very much intertwined with the discussion at the AGM and the proposed bylaw amendments. So I would, given that we've compressed the time, I don't know how to do this procedurally, Dr. Viswanathan, but I'm wondering if I could, if somebody, an RA delegate, might consider a motion to, I want to know how to best facilitate the presentation on the Special Committees of Governance's report tabled at a special meeting, because we can't give it the time and attention today, and we can't lose it. So we do need to reconvene as a community to have that discussion. So that's my wish, and I'll pass it back to you where you see hands in the room.
So 2 delegates. As you've heard, it will be challenging to get through the report on SMA governance. It is on the agenda, but it is possible that a delegate could make a motion similar to what we just heard to postpone it to a special meeting. And so I see a hand up from Dr. Epp. Dr. Epp, would you come up here and we can put you on just next to the stage and we can put you on video. Dr. Epp, do you have a motion to make?
Yes, I do, and this is another very friendly motion. Can you guys put it up? So in the spirit of giving this topic the time and reflection that it needs, and the fact that we are constrained by time and by virtual gathering today, I would like to propose a motion that, oh, where did it go? Okay, So that we consider the special committee report be deferred to coincide with the special meeting of the membership.
There is a motion proposed, be it resolved that consideration of the special committee report be deferred to coincide with a special meeting of the membership.
And that should say governance committee, I'm sorry.
Membership, special meeting of the governance committee. So we're just going to change that so everyone can see what the intent is.
It's the,
Hold on.
it's the, yes,
Just a moment.
just so we get the right committee. Sorry.
I'll read it, but if you can just take a quick look at it and make sure that's what you intend, Dr. Epp.
Yes.
Be it resolved that consideration of the special committee on SMA governance be deferred to coincide with a special meeting of the membership.
It's the report, actually, that they were going to give today, so.
We'll change that. 1 second.
Moved by Dr. Epp. Dr. Jeffrey, you're listed as a seconder. Is this still okay with you? Seconded by Dr. Jeffrey. Is there any discussion, any debate? There are some questions. Who's first, please?
We have Dr. Letting's hand raised.
Dr. Letting, please go ahead. You have 2 minutes.
That's fine. I won't be that long. I just want to speak in favor of it. I think that some of the things that Brian's brought forward are valuable. They warrant discussion. Whether we end up on the same page as him isn't really important. Brian has the experience. I respect what he's picking up, and I don't want to see it missed. So I want us to carry on and get this right, because governance is important.
Are you speaking for or against this motion?
I think I said it for in favor at the beginning, but sorry if I didn't.
Thank you. Any other questions?
We have a hand raised from Dr. Stoneham.
Dr. Stoneham, please go ahead.
Yes, Dr. Stoneham from Saskatoon, a member of the RA, but also a member of the special committee. Could I just get some clarification as to whether that means that the special committee itself is extended in the future? My understanding.
Audio is really fading out here.
Sorry, my understanding is that the committee was only constituted until this meeting to report back to the spring meeting of the RA. Is it the intention of this that the special committee itself is extended until this special meeting of the membership? And does that need to be clarified in this motion? Did you hear me? I'm sorry.
We did hear you. There's just some discussion. Please.
I'll speak to that, and the answer is yes, that the special committee, please, would remain in place at least until the time of the special meeting, give their report.
Any other questions? Seeing no other questions, we will move to a vote. Now, we are back in the RA, so we're moving back to Slido voting. Yep. So you should still have your Slido window open. If not, please open your Slido browsers. Sorry. Hold on for that for a second, please. Right. Sorry, I've been corrected. We have not moved on to back to the RA, so this is still part of the AGM. So we're staying in your Zoom window. So please vote in your Zoom window, just as you have been doing for the last hour, and you will have 20 seconds. I'd like to open the polling now. Polling is opened. Polling is closed. That motion has carried. So the special committee report on SMA governance will be deferred to coincide with the special meeting. We will carry on with the RA, moving to resolutions. Because we've had a change in the agenda, give me a moment, I'm going to cast my eyes about the room and make sure that that is satisfactory to everybody in the room. So I'm looking at Tanessa and I'm looking at Bonnie. I'm about to move on with resolutions. Regular resolutions, yes. Great. Okay. Welcome back to the RA. As you know, this morning, we already tackled Resolution 11 and Resolution 12. Those were both carried. We're going to move on with Resolution 13, which is aligned with Resolution 12. You may remember that that addressed the International Classifications of Diseases codes. Can I see Resolution 13? And as a reminder and reorientation, we'll be using Slido to vote in the RA. Resolution 13. It'll just be a moment. Resolution 13. Be it resolved that the Saskatchewan Medical Association work with all appropriate agencies to ensure that the use of classification of diseases, ICD codes, is updated to current standards in order to reflect the current disease classifications. Moved and seconded as you see on the screen. Dr. Konstantinowicz, would you like to speak to this as mover?
I would. Thank you, Dr. Visvanathan. The current system of identification of a single and old ICD-9 system handicaps our healthcare system in many areas. We may fail to link medical conditions together, understand the burden of disease, fail to build appropriate pathways, patient support, and develop solutions to ensure a healthy population. As I mentioned earlier, the ICD-9 coding system was first published for use in 1975. The most up-to-date WHO ICD system is ICD-11, which came into effect in January of this year. Additionally, only one ICD code is collected by the system, which creates a significant loss not only of understanding of conditions, but the true burden of illness and disease. Collecting this important information can provide both categorical data, disease X, yes or no, as well as numerical data, how many cases do we actually have. Additionally, we can start to understand how issues of race and gender impact on workload. I'm happy to take any questions.
Is there any debate on this motion? Any questions?
We have one question from Dr. Hollinaty.
Dr. Hollinaty, please go ahead.
Hi, can you hear me now? Perfect. So I'm the seconder of this motion, and I just wanted to provide a little bit of extra information. There are still a lot of those ICD codes that when we enter them have truly offensive descriptors associated with them. So there are still things with descriptors like hysterical, XYZ. Every time that you see a transgender patient and try to build gender dysphoria, it gets changed to frigidity as the descriptor, which is obviously not appropriate. And so not only is this reflecting sort of current realities, but we need to be able to update this to a standard where we're not actually having to submit offensive descriptors of the conditions that we're managing. Thank you.
Thanks, Dr. Hollinaty. Any other debate on this motion? There are no other hands raised. So delegates, please open your Slido browser. You'll have 30 seconds to vote. I'd like to open the polling now. The polling has begun. Polling has ended. This motion is carried. Resolution 14. Be it resolved that the Saskatchewan Medical Association Board of Directors engage in discussions with the Ministry of Health to formulate a Saskatchewan Rural Health Professions Action Plan. Moved by Dr. Loden, seconded Dr. Redekop. Dr. Loden, as mover, would you like to speak to this?
Yes, thanks for the opportunity to speak. So I'm Steve Loden, a delegate from Meadow Lake. And I was encouraged today by Ministers Merriman and Hindley and their discussion on the development of a health human resource plan. And perhaps this resolution has some crossover with that plan. I certainly understand that there's pressures across the system, and that's not exclusively a rural issue, but I do believe that there's a lot of deep-seated and complex issues that precede the pandemic in our rural settings. I just think in general, we need to be more coordinated in our strategies to providing healthcare services locally. And we have to look at the whole team approach in order to accomplish that. One simple example is in Meadow Lake, we have quite a skilled team of physicians, nurses, and OR staff for obstetrics, but we do not have any local obstetrical ultrasound services. And our patients will have to be transferred out if we don't have enough nurses to staff the hospital ward over the summer. So I'm sure each community has their own unique challenges that would be similar but different. In context, our neighboring provinces, BC and Alberta, do have dedicated institutions for this cause. That's the Rural Coordination Center of BC and the Rural Alberta Health Professions Action Plan. So I just wonder if perhaps our SMA board can work with the ministry to design and implement this approach within the Health Human Resources Plan. Thank you.
Thanks, Dr. Loden. Is there any other debate on this motion?
We have a hand raised from Dr. Groves in far northeast.
Dr. Groves, we'll put up a 2-minute timer for you. Please go ahead.
Thanks, Kishore. So I'm Sean Groves, I'm a physician in La Ronge and RA delegate, also our local MSA president. I just wanted to, just really support kind of Steve's resolution and also kind of draw attention to the Society of Rural Physicians of Canada working group that has put together a roadmap for rural medicine, and it's a multi-level plan. And for those physicians that are kind of interested in this work, I think it's definitely worth looking at that roadmap for how we improve services in rural communities. And I also want to put in a shameless plug for something that we're trying to set up. I'm trying to set up kind of personally, not directly involved with the SMA or the Committee on Rural and Regional Practice, but a WhatsApp chat group for rural physicians who want to discuss these issues. So if you're at all interested in being part of that group for discussion, it's going to be fairly informal, but I'm trying to get as many rural docs on, and this is a good group to hit with. So sorry to take up some time on that, but just contact me or contact Julie Yu through the SMA to get onto the chat group. That's all I got. Thanks.
And sorry, it kind of sounded like I was putting up the timer specifically for you. I just wanted to make a general announcement about it. Also, you never have to preface any of your comments by shameless. We know you are. Any other debate about this motion?
We have a hand raised from Dr. Letting.
Dr. Letting.
Yes, this is no small issue. In Old Heartland, which served 45,000 people and was the biggest rural area in the province other than the north, we don't have an ultrasound technician in the whole area. We've shut down bigger hospitals because they don't have enough nurses, and the overload is coming on to my community in Rosetown. And it just kind of goes on. They've eroded the lab services. This is not small stuff. We have become dysfunctional, and the whole problem goes back to insufficient training of enough people to do the job. And let me throw in the fact that that applies to physicians as well, where we need to set up a rural stream that actually is rural and functions and provides special skills. But the baseline for everybody else that we work with is the training programs are not there. This is becoming just unacceptable. Amen.
Dr. Letting. Any other comments? There are no further hands raised, so we will move to a vote. Delegates, please open your Slido browser. You will have 30 seconds to vote. I'll start the voting now. Voting has begun. Polling has ended. This motion is carried. Resolution 15. Resolution 15. Be it resolved that the Saskatchewan Medical Association urge the provincial government to initiate an independent and fulsome post-pandemic review of Saskatchewan's response to the emergence of the novel coronavirus SARS-CoV-2. Moved by Dr. Khan, seconded by Dr. Apondo. Dr. Khan, as mover, would you like to speak to the motion? Dr. Khan, are you on the meeting?
Can you hear me?
Thank you. Yes, we can hear you now. If you can turn your video on, we'd appreciate it.
Okay. So as we know, SARS-CoV or COVID resulted in unprecedented pan-social response, and the circumstances were unlike those not seen for generations, and arguably the first time our current Saskatchewan. We see not only Saskatchewan, Canada, but throughout the world. So we understand that there were some vulnerabilities and strengths in Saskatchewan in our system. So there's an opportunity for the government to look into it and review the whole system, what we learned from this pandemic and how we can cope with the same calamities in the future. So as physicians, we know that a commitment to continuous quality improvement and quality assurance includes a need to look at such challenging events with openness to learn both from successes and failures.
Thank you, Dr. Khan. Is there any debate on this motion?
We have a hand raised from Dr. Opondo from Public Health.
Dr. Apondo, please go ahead.
Thanks, Kishore. I don't know if my video is up. This juggling is really good and good exercise. But yeah, I think the motion is quite clear. I just want to make a quick, I'm seconding the motion. And this practice of doing after action review or a hot wash, or it goes by a number of synonymous terms, but the main thing is capturing our learning and our experience with COVID-19 as a profession in a structured way, so that we learn where we did well, we learn where the mistakes were and the pitfalls. And really, the review that we're asking for is not really necessarily a punitive exercise, but it's really more to understand where we as a system respond to threats. And we do have, residual consequences of COVID-19, which we're all experiencing in terms of delayed diagnostics, backlogs, you name it. So I second this motion, and partly I think it's quite self-explanatory, but I just wanted to add context on why this is important before the vote is taken.
Dr. Opondo, is there any other debate on this motion?
We have a hand raised from Dr. Ndubuka from North Central.
Dr. Ndubuka, please go ahead.
Thank you, Mr. Speaker. Dr. Ndubuka here, MSA North Central, unit of public health section. I would like to speak in favor of this motion, and I think for obvious reasons. Number one is that there is opportunity for us to clearly document, our strengths and also opportunities for improvement, recognizing that this is consistent with best practice. Secondly, it will also give us an opportunity to see what we could do differently in the future in the likely event that we face another pandemic, because for sure, there might likely be one even in the future as we go along as a province. So what could be done best needs to be documented here. I also want to support that we take this very seriously, recognizing the impact that it has had on our population within the province. Thank you, Mr. Speaker.
Thank you, Dr. Ndubuka. We have another question.
Have another hand raised from Dr. Thorpe, South Central.
Dr. Thorpe, please go ahead.
He's not actually there.
Dr. Thorpe?
Sorry, I wasn't unmuted. I guess my only comment on this is that while this to me is a bit of a nice to know, I fear about the cost and wasting significant resources and money in a third-party investigation. Is it really going to impact us in the future? Maybe it will if we have a different government, but from my experience over the last 2 years, I don't think that this government listened to anything that was presented to them anyways. So I just wonder if this is just an academic process more so than an actual helpful process. And so I actually speak against this motion.
Thank you. Any other debate?
We have a hand raised again from Dr. Opondo.
Dr. Opondo, please go ahead.
And I think I'm just reading the resolution itself. I don't think, even though it says independent and fulsome, it's not necessarily asking for a third-party review or a contracted service to do this. This is more reflective learning for us. I think that's the spirit in which this motion was raised, just for clarification. And I don't know if the resolution needs to.
Thank you. Are there any other hands raised? Seeing no other questions, we will move to the vote. So please open your Slido browser. You will have 30 seconds to vote. I'd like to open the polling now. Polling has begun. Polling has ended. This motion is carried. Resolution 16. Be it resolved that the Saskatchewan Medical Association advocate the Ministry of Health to remove the cap of 3,000 virtual care consults per year for payment by Medical Services Branch, Saskatchewan Health. Moved by Dr. Pillay, seconded by Dr. Mula. Dr. Pillay, as mover, would you like to speak to this motion? Sorry, Dr. Lenny Pillay.
Thank you, Dr. Viswanathan. Mine is straightforward and simple. I was approached by some of my family practitioner colleagues in the midst of the pandemic regarding this cap. So I'm hoping that we can move forward with this. We know that virtual care has been well received by the public and physicians countrywide. There's a 91 to 94% acceptance according to a CMA poll. Virtual care and virtual care codes have been endorsed by the CMA, and there's multiple emails and posts from the CMA. Their value has also been reaffirmed with many studies. Virtual care enhances our value to patients. It reduces time away from the regular routines. For example, to receive a simple lab, X-ray, or CT results, to be sitting in an office 3 hours away, coming to the specialist office seems to be a waste of good time that the patients can put to something more useful. And it reduces travel time and time off work for the patients. It enables the patients to be more productive and more active and contribute to the economy and the tax base. So based on this, I would suggest that we look at removing the cap of 3,000 on virtual care consults, and hopefully we can look into that. Thank you.
Thanks, Dr. Pillay. Do we have any other debate on this motion?
We have a hand raised from Dr. Elise.
Dr. Leese, please go ahead.
Okay, thank you. I think I'm unmuted now. So there's no question, major benefit to virtual care. And I think Dr. Pillay outlined that really well. I think my concern with the way the resolution is worded is that I agree that virtual care has the most benefit for simple things where patients have to travel, for example, prescription renewals, labs, general reviews of simple issues where a physical examination is not required. I just fear that removal of the cap might facilitate an abundance of virtual care that might not be as helpful or distract us from the importance of being in person. And so I agree the cap probably should be removed, but we shouldn't lose sight of the fact that virtual care has a role for certain conditions and certain follow-ups and should not be viewed as equivalent to an in-person consultation. Thank you.
Thanks, Dr. Leese. Any other debate?
We have a hand raised from Dr. Brown from South Central, or Southeast.
Dr. Brown, please go ahead.
Hi, thank you very much. Yeah, I mean, I can understand the intent of the motion. When you do the math, 3,000 virtual care visits a day, if you think that you work maybe 48 weeks of the year, that's about 16 to 17 calls a day. And I know that one of the difficulties that's happened during the pandemic is trying to get physicians back into the offices, seeing face-to-face people. And I know that there's some patients that get frustrated because their physician is never available for an office visit. So I think there needs to be a balance. So I don't disagree with the motion, but I just think that it's a balancing act between encouraging face-to-face care once more, but not ditching virtual care. So maybe a cap is the right thing. Maybe the cap needs to be adjusted.
Thanks, Dr. Brown. Any other debate?
We have a hand raised from Dr. Thorpe.
Dr. Thorpe, please go ahead.
Sorry, and just to comment, my video doesn't work on this computer. I agree with Mark. What I was just going to say is I think maybe the adjustment to the cap is more appropriate. One of the problems we definitely have had is trying to encourage physicians to get back to seeing patients in person. And one of the complications and complaints I'm getting from patients is not so much family doctor virtual consults, but referrals to specialists who are seeing patients virtually instead of in person. When I'm doing a referral to a specialist, I'm actually expecting the specialist to see the patient. Otherwise, I would have requested a virtual visit. So I'm getting a little frustrated. Some of the patients are getting a little frustrated that some of the specialists are just doing virtual care. There are doctors who, when you phone their offices, actually tell you that they're not doing in-person care. So I think we need to start moving back towards proper medical care for our patients. And so maybe just changing the cap is the way to go, because I do understand that virtual care is important in certain aspects. Thank you.
Thank you, Dr. Thorpe. Are there any other speakers?
Next, we have Dr. Garcia from Southwest.
Dr. Garcia, please go ahead.
Thank you. I was having trouble with the unmute. To speak to a couple of issues, I know that there was the first comment around getting to the cap being a bit difficult over the year. Certainly as a specialist who does look after a lot of areas that family doctors are not comfortable taking over the care. I have lots of patients who are from 4, 6, or 10 hours away, and it's just not fair to ask them to drive because we've hit some cap that really doesn't have any relevance to my care. As some of you may know, I'm only one of 2 urologists that do a lot of sexual medicine stuff in the province. So I do have to deal with a lot of virtual care in that regard. The second is that, there are lots of consultations and things, for example, that do require in person, but there are plenty that, especially in urology, that we can identify that do not. For example, the following up or assessment of a renal mass, it's all based on imaging. Physical examination doesn't help us at all. And these are some of the ones that I think specialists are realizing that we can save a patient several hours of driving for a visit that could just be done virtually and with local imaging resources. So I do support in the removal of the cap, even though I'm only in clinic 2 to 3 days a week. I do find myself getting close to that cap virtually every year. And I can only imagine that those who are in clinic more often than me might be able to achieve that without much effort.
Dr. Garcia, any other debate?
We have Dr. Hayton, Saskatoon.
Dr. Hayton, please go ahead.
You guys can hear me?
I can hear you.
Yeah. Hi. So I want to echo some of the concerns about virtual care and being sure that patients are not disadvantaged by not being seen in person when they need to be. That being said, I think you've heard from people also who say that for them, virtual care can be very helpful and very helpful to the patients. And I am opposed to having the government decide when we should be seeing patients in person or not. I think that's something we should deal with internally. We should educate ourselves and our fellow physicians of the importance of making sure that we see patients in person when they need to be seen. But I don't like the government putting a cap on us and deciding what kind of practice which we should be carrying out as professionals. So that I would vote in favor of the motion. Thanks.
Thanks, Dr. Hayton. Any other debate?
Next, we have Dr. Parai, Regina.
Dr. Karai, please go ahead.
Okay, so I tend to agree with what Dr. Hayton just mentioned, and that was actually going to be my point, that I also am not in favor of the government arbitrary caps on virtual medical services, limiting the services that we can offer as physicians. It should be up to us to decide which patients are appropriate to be seen on a virtual level versus in person. Just on another point, I would like to say that I think this is one piece of a larger discussion that we need to have on virtual care moving forward, considering the looming corporatization of virtual care, the recent governmental deal with Lumecca to offer virtual care to the province of Saskatchewan. And these are also pieces that we need to be vocal and have physician representation through the SMA in directing the future of what that looks like in Saskatchewan.
Thanks, Dr. Karai. Any other debate?
We have Dr. Letting, Central West.
Dr. Letting, please go ahead.
Thank you. I have mixed feelings on the issue. I think virtual care has been great. This suggests, as other speakers have mentioned, removing the cap. I think I'm in favor in some ways of having a cap, because I've seen the other side of the coin where some physicians are really not practicing good medicine and doing a lot of virtual care. I have sent in individuals with, cancer of the throat because they've never been examined. I've heard physicians say, well, I'm not going to see these people. I'm going to just do more virtual care. 15 a day, I'll never get to that personally because I don't believe in that amount. So if you adjust it and the motion doesn't say that, I'd be okay with going higher, but I'm not really wanting physicians to get the idea that medicine is about not seeing patients. So do we need an amendment to this to adjust the cap? Because both Mark and Brandon have mentioned that, and I agree with them.
Are you proposing an amendment to this resolution, Dr. Letting?
I'd be glad to do it.
Please state your amendment.
Simply that we change from remove to amend to increase the cap.
The cap to what amount?
I'm willing to listen to suggestions on that. If you go up to 4,000, for example, I think that's a step. We can review it again in the future.
What's the amendment you're proposing?
To increase the cap to 4,000.
Okay, so there's now an amendment to this motion. So until I indicate otherwise, discussion and debate is going to be about Dr. Letting's proposal to amend this resolution to increase the cap to 4,000 virtual care consults a year. Is there any debate on that amendment? So please, if you have your hand up and you were wanting to speak to the original resolution, can you please lower your hand? And we will call on you if you want to speak to this amendment.
We have a hand raised from Dr. Pillay.
Dr. Pillay, please speak to this amendment.
Thank you, Dr. Viswanathan. Thank you, Dr. Letting. I think the intent of this motion is that there should not be a cap. And as we heard from speakers supporting the motion, that the control on the number of consults is what the point is here. I personally agree with you that I probably do 2 or 3 of these a week. And it's certainly not the intent to have somebody sitting at home and only doing virtual care consults. I think the intent of the motion is that there shouldn't be a limit on the number of virtual care consults. I would find it very hard if you look around this room, if anybody is doing 5,000 virtual care consults a year in the past 2 years. So although I like your idea of the cap, unless the room feels that we should have the cap, I don't agree with having any cap on the number of virtual care consults. Thank you.
Thank you. Is there any other debate on Dr. Letting's proposed amendment?
Yes, we have a hand raised from Dr. Thorpe.
Dr. Thorpe, please go ahead.
Thanks, sorry. The mute is slow. Actually, on consideration, because I know I originally mentioned that I would perhaps increase the amount of virtual care after I heard the other discussions about the control of the cap. I actually sort of retract my thoughts and change my thoughts. I'm not in support of Dave's motion, even though I was probably the instigator at the beginning.
Thank you. The current debate is around Dr. Letting's proposal to amend this resolution to increase the cap to 4,000 visits. Is there any other debate on this amendment?
Dr. Letting has his hand raised again.
Dr. Letting, please speak again.
I don't think this has even been seconded, has it? Not wanting to speak against myself, but my concern is about some controls. I haven't got a seconder, have I?
No, thank you for bringing that up. Has no one spoken for this motion yet? Someone has agreed that the motion is worthy to be spoken to. We've had 2 people speak to it. And so technically a seconder does not have to support the motion. A seconder is just agreeing that it's worthy of discussion. So unless Dr. Pillay has a disagreement of being included as a seconder because it was worthy of being discussed, I will ask that he let us include him as the seconder. Dr. Letting, do you want to speak further to the motion?
Can you hear me?
Yes, we can hear you. Thanks.
Okay, well, my concern is that I want to see it increase to some point, and I do not want to see it reduced. I know this has to be negotiated no matter what we do in the end, so what we put on top of it isn't going to matter. As long as we make the motion that it needs to be a larger number than it is, I'm easy going.
Thank you. Is there any other debate on this amendment? Seeing no other hands, we are about to vote solely on the amended wording to this resolution, then we'll come back to the resolution. So when you're voting now, if you are voting in the affirmative, you are saying that you want this resolution to read cap of 4,000 visits. If you vote against it, then we will still come back to the original resolution and you'll get a chance to vote on that. So I would like to open the polling now. You will have 30 seconds to vote. Polling has started. Polling has ended. The amendment to the motion is defeated. We will now return to the original resolution, and we can continue debate on this original resolution. Is there any other discussion?
Yes, we have a hand raised from Dr. Groves.
Sorry, who is it?
Dr. Groves.
Dr. Groves, please go ahead.
Thanks, Chair. I wanted to speak in opposition to this resolution, and it mainly has to do with some of the comments that were brought in earlier around the fact that we need to do a lot of work as a profession on how we manage virtual care. I have no problem with this as a stopgap measure to avoid unscrupulous abuse of virtual care models, in particular by physicians who work for large corporate entities and plan to provide the majority of their care through virtual care, because this limits their ability to do that. And I'm actually in favor of that. Maybe others aren't. So again, as a stopgap, I don't see this as a major issue. And anyone who's seeing between 13 and 16 virtual appointments every day of their working day, that's a lot. And I do understand that there are providers out there that require or are able to do a lot of their work without in-person visits. But I think as a profession, as a group, as a medical association, we need to be careful in terms of how we navigate this. And I definitely don't want the government to tell us how to do our work either. But I think the flip side of that is then we actually need to take responsibility for making recommendations. We need to work with the College of Physicians and Surgeons on this, and we haven't done that to date. So I'm actually in favor of the cap as it stands currently, with the caveat that at some point we need to really reassess virtual care in general.
Thanks, Dr. Groves. Next point of debate, please.
Dr. Pillay.
Dr. Pillay, this is your second time speaking on this point. Please go ahead.
Okay, thank you very much, Mr. Speaker. To address Dr. Grove's point, I agree that there's a separate point where we need to discuss the parameters for virtual care. And actually, the college has already put out a letter. I'm not sure if you have read this. It was sent out on the 11th of April, 2022, and it gives guidelines to virtual care. It's not an absolute list, but it's really a comprehensive list that you can follow. So the college is already working on this, to my knowledge, and I'm sure we have college representatives sitting and listening in on this conversation, and perhaps they can chip in on this. But certainly your point is taken that virtual care is something that has helped, but we shouldn't be seen as the only way to treat our patients. I think it's part of our little things that we have in our back pocket to use. So virtual care together with inpatient care is an important part of our practice moving forward. Thank you.
Thank you, Dr. Pillay. Is there any other debate? Seeing no other hands raised, we will move to vote on this resolution. I'm going to read it again because there wasn't an amendment. It's the original resolution. Be it resolved that the Saskatchewan Medical Association advocate the Ministry of Health to remove the cap of 3,000 virtual care consults per year for payment by Medical Services Branch, Saskatchewan Health. So please open your Slido browser. You will have 30 seconds to vote. I'd like to open the polling now. Polling has begun. Polling has ended. This motion is defeated. Oh, what's that noise? That's the biologic alarm I set this morning at breakfast to remind me it's lunchtime. So we will now break for lunch, well-deserved I might add, and we will reconvene promptly at 1:15. I'll see you at 1:15. Welcome back to the SMA Representative Assembly. I hope you had a great lunch break. I certainly had a delightful lunch here, courtesy of the catering staff at Saskatoon Inn, so thank you to them for that. I wanted to give a reminder, we had some questions from participants in today's meeting about where's my Slido code? Only delegates to the Representative Assembly can vote on Slido, so if you're looking for your Slido code and you're not a delegate, you don't have a code. You're not entitled to vote. Before we move on with this afternoon's business, I've been advised that Dr. Strydom would like to provide some updated information on the status of the Special Committee on Governance, speaking to some of the questions that were raised this morning. Dr. Strydom?
Thank you, Dr. Viswanathan. So just to remind the RA, at the fall 2021 RA, the Assembly asks for the creation of a special committee on governments to be struck from election of RA delegates. So the RA agreed to the terms of reference, and that would have had the special committee continue its work until such time it could actually present those findings and recommendations to the RA. So this resolution was presented earlier today to defer the receipt and presentation of this report to another time and date. We'll see or need the special committee will need to continue with its work. So one of the members of the 5 representatives on that committee was not re-elected to the RA, and hence a vacancy occurred on the committee. So the board had a discussion regarding this yesterday, and a recommendation was made, which I would want to bring forward to the RA, and that's basically the unsuccessful candidate that applied for the original committee. The candidate with the most votes be appointed to the to this vacancy on the committee. So consequently, the nomination would then go to Dr. Lenny Pillay, and the recommendation is that he be appointed to the committee. So I would like to present the following resolution. Be it resolved that Dr. Lenny Pillay replace Dr. Cecil Hammond as a member of the Special Committee on Governance. So I will move that, and it's seconded by Dr. Alanathe.
Thank you. Thanks, Dr. Strydom. The resolution is on the screen in front of you. Do you wish to speak any further to it?
I think I'm clear on that if there are any questions.
Great. Is there any debate on this motion? We'll just give it another moment. No. There are no questions, so we will put this motion to a vote. Delegates, please open your Slido browser. You will have 30 seconds to vote. I would like to open the polling now. Polling has begun. Polling has ended. This motion is carried. We'll proceed on according to the agenda. We know that sections have been meeting over the past few weeks, and we look forward to hearing from them, as well as from other members and delegates on important topics affecting the profession. We will now open the floor to delegates who have business that they want to bring to the Assembly. Again, if you would like to speak, please virtually raise your hand on the Zoom platform, and we will announce and recognize you. Any business to come forward to the RA?
We have one. We have a couple questions from the floor, starting with Dr. Garcia.
Dr. Garcia, please go ahead.
Hi again. I just wanted to, and I'm not sure if this is the appropriate venue, just to ask for some further updates on some of those old resolutions that we had a chance to review, particularly the one that we had put forward in 2019, myself and Dr. Jevray, that I asked for updates for at the last SMA, for the database that was searchable for interests for referring purposes, especially now in the age of virtual care. When I looked at it, it just says, and note that to check if the project is feasible, and it seems a little bit excessive that it takes 3 years and we're still not sure if the project is feasible. I'm just wondering, what is the follow-up and how is it being determined if it's feasible? Just because to create this database that I was requesting, at the risk of sounding a little flippant, would probably take a weekend and a box of pizza, and he or she would have it done. So I'm just wondering,
Sorry, your audio faded out for me just when you were saying what the resolution was about. We want to have an update on it, but just say again what the resolution was about.
Well, I can specify. It was resolution RA 19S-12, specifically on the creation and maintenance of a searchable database of physicians, which lists practice interest preferences and estimated wait times. It was indicated to check the project is feasible, and that was 3 years ago. It seems a little excessive for 3 years to pass and us to not even know if it's feasible. I'd like to know what the holdup is. I'd like to know how we're determining its feasibility.
I will survey the room and see who can address that, and it looks like Ivan Muzichka is going to address that for us.
Good afternoon, everyone. Thank you, Mr. Speaker. It's my job to sort of shepherd these resolutions through. As I mentioned, or as Bonnie mentioned this morning, we are working through sort of an audit of all resolutions that have come through. There is a backlog. There's a lot of them we did clear from 150 resolutions down to what we have here. When I say clear, we basically went through and studied and made sure that a resolution was discharged, or it was stale, or it's been abandoned for a good reason. This one, to me, by the looks of it, came in just prior to in the spring, prior to the pandemic. And all I can recall from this is that when I say we were studying the feasibility of it, it was something that I couldn't just do myself, or 2 or 3 staff members, we would need to reach out and get physicians and so on. Probably what happened there was that, while the work got delayed, because there's a lot of work in the spring after the resolution and into the fall, that it probably was brought forward, and then the pandemic hit. And when the pandemic hit, we did have a lot of resolutions. We did get some new ones, and a lot of those got put aside because the pandemic work was more pressing for obvious reasons. Now, that's all an excuse, really. I will say that, you know, a lot of this work should be done and will be done. But, you know, for the last couple of years, it's been hard to move on some resolutions, especially ones that require a little more work. Like, I don't think that one, if I look at it again, you know, it seemed to me that there needed to be some kind of work on this searchable database. And, you know, again, it wouldn't be us to create it. I don't know how easy it is to request the Ministry of Health create a database and then say, well, and maintain it. Like, to me, there are a lot of moving parts to this particular resolution. So I don't know if that answers your question, but I think that's where
If I can
it comes in.
paraphrase or recall Dr. Garcia's intent, and he's welcome to add to it, I think he was looking for the feasibility study, and I think he was looking for a time frame. Are we able to give him a time frame on completion of a feasibility?
Yeah, sure. But so all I can say with this one is, my goal is to report back to the fall RA with this report updated, together with any resolutions that are passed today. So I will pull that out and see whether or not what's going to happen with the feasibility, quote unquote, and whether or not we're going to move ahead with this one. So yeah, I mean, part of that discussion I can have with Dr. Garcia and with the mover and
Thank you.
seconder here.
Thank you. Do we have another question?
Thank you.
The next hand raised is from Dr. Zarabitsky.
Pardon me?
Dr. Zarabitsky?
Dr. Zarabitsky, please go ahead.
Yeah, I don't know if it's the right time or not, but I heard then we have an opportunity to put motions for election, like vice speaker. So I would like to propose Dr. Jay Calra for that. So is it right time or is it going to be?
There will be elections later in the program, so you're just about exactly right on.
Okay.
Just a little bit early, but let's hold that idea.
Okay, let's do that.
Thank you for bringing that forward. Next comment, please.
Next from Dr. Thorpe.
Dr. Thorpe, please go ahead.
Thanks. Dr. Garcia, I missed the first part because your audio was a little bit weird, but I think you're talking about the sort of a surgical waitlist searchable database for who does what and where and all that. If that is what you are asking, we just had the ministry and the SHA actually had a meeting kickoff session this week where that's exactly what we're trying to build. And what we're doing at this point is we're going to be reaching out to family practitioners, to surgeons of different disciplines, and also to patients to get a feel of just to get some information about patient flow, where they would go, where they would like to go, how they would feel about being told to go to a shorter wait list in a different area. And not only that, but then to build that database and improve the database so that we can go to a link, and there is one already online, but to improve it and make it functional. So I don't know if that helps answer your question somewhat. The SMA was not represented at that meeting, but certainly the ministry and the SHA were. And there were family practitioners and surgeons and ministry and admin as well.
Thank you, Dr. Thorpe. Next speaker?
Next speaker will be Dr. Salou.
Dr. Salou, please go ahead.
Hi there. Hi, thank you for having me. My name is Dr. Salou. I'm an adult psychiatrist based in Regina. Thanks to all of you who have made note of the current crisis in mental health care in Saskatchewan today and for your advocacy earlier. I'm asking to have this moment so I can draw attention to our recent resolution that we put through with Dr. Prasad and Dr. Jean Marcoux as a second as our delegate, in that our colleagues are struggling in that there is no parity between virtual care provided and in-person, that there is no parity currently between virtual care and in-person care for psychiatry, which is not helping us when we are trying to service as many patients from as many locations as possible, especially during the pandemic, and when we're in a field that doesn't require physical exams per se. So we are looking for as much support as we can get here from our colleagues. We're trying to keep things accessible for patients to come and see us, but we can't do that when I personally am now behind on my clinic rent because of that much difference between what I make in person and not in person when my patients are sick at home with COVID and can't come into clinic. So please, I don't know of any other province that has such a pay disparity between in-person and virtual psychiatry. It's completely unacceptable in 2022. And I would like for some support from our colleagues across the province in speaking to this. In addition, I was the only psychiatrist in Regina and adult psychiatry accepting new patients at all for the whole of last year. And I'm now having to close because my wait list is simply too big to manage. I'm the only woman psychiatrist working in adult psychiatry in Regina. We don't have a single nursing staff or social work staff for all of mental health care for maternal and postpartum depression. And so we're working hard with our colleagues in OBSGYN to lobby the Ministry of Health to give us some resources. We want to be on par with other states like who have dedicated so we would just like support from our colleagues.
Thank you.
So that we can get more people.
Thank you very much. Next speaker, please. There are no other questions, no one else waiting in line. We'll just give that another moment. No, thank you to everyone who brought business from the floor, representing your region or your section. We will carry on with resolutions. We're moving on to Resolution 17, taking up where we left off this morning. Resolution 17. Be it resolved that the Saskatchewan Medical Association advocate the Ministry of Health to have virtual care consults be remunerated at the same rate as in-person care. Moved and seconded, Dr. Pillay and Dr. Mula. Dr. Pillay, as mover, would you like to speak to this motion? And just while we're getting Dr. Pillay on the line, another reminder is that at our end, that is our technical team, they will unmute you. So if you're struggling to get unmuted, just give us a minute, we'll unmute you. Dr. Pillay, thank you.
Thank you, Dr. Viswanathan, Mr. Speaker. I went through the gambit about virtual care, and Dr. Salu created the perfect segue into this particular motion. I believe there's another motion from the section of psychiatry that's along the similar lines. So we all know that virtual care has played a very important role through the pandemic. And when we look retrospectively and prospectively, that virtual care will continue to be an important part in our care for patients. You know, Dr. Ledding, I'm going to quote him here last year when I brought up the resolution regarding the 769A code. And Dr. Ledding said, the principle of a payment for a service is that if a doctor delivers a service, it should be remunerated appropriately. So, you know, if we are delivering a service as physicians in person and you're delivering the same service, for example, discussing an MRI result over the phone or video, as opposed to doing that in your office, you're giving the same information, answering the patient's questions, ensuring that the patient has care. I believe that we should be remunerated equally for either an in-person consult or a virtual consult. So with that spirit, I would like to resolve that the Medical Association advocate for having virtual care consults to be remunerated as the same rate as inpatient or in-person care. Thank you.
Thank you, Dr. Pillay. Is there any debate or discussion on this motion?
We have one hand raised from Dr. Hayton.
Dr. Hayton, please go ahead.
Hi, I know this might seem like I'm arguing against myself here a little bit, but I am a proponent of in-person care where I think it's needed. And although I think probably in the case of psychiatry, it's maybe a different matter because so much of a psychiatric evaluation obviously is discussion rather than hands-on assessment. But nonetheless, I think that a consultation in many disciplines involves actually seeing the patient in person and touching the person's body or listening to their chest or whatever. So I'm a little bit anxious about asking for the same remuneration for consultation that is virtual as well as in person. I think there should be some distinction for some disciplines. So I think I may be inclined to vote against this motion.
Thank you.
Our next hand raised is Dr. Ndabuka.
Dr. Ndabuka, please go ahead.
Thank you, Mr. Speaker. I personally don't have any issues with virtual care. Of course, we know given the pandemic, the virtual care services are here to stay. It does have relevance, but I'm really concerned that if we advocate for equal remuneration, either via for services provided either via virtual care or in-person consults, that might gradually erode the need for in-person care, which from the previous resolution, we did hear comments that that's beginning to be a concern where patients are finding it difficult to get in-person services and colleagues are leaning towards virtual care. So this resolution would likely erode that benefit of patients getting care in person. So I will personally vote against this resolution. Thank you.
Thank you. Next speaker.
Our next question will be from Dr. Lowry.
Dr. Lowry, please go ahead.
Hello, I just wanted to add to the comment about psychiatry. We are a little bit different in that with the recent changes to the fee code schedule, the difference between our virtual code and our in-person billing, virtual pays 67%. This is upsetting a lot of the psychiatrists, as it is our understanding that the other specialties are getting 90% of their regular fee codes for seeing people virtually. And that does not make sense to us as a difference. And so I think we are really advocating for at least equality to the other specialties to at least receive 90% of what would be in person if we see people virtually.
Thank you. Next, please.
Next, we have Dr. Dewar.
Dr. Dewar, please go ahead.
Thank you. I would like to speak to this motion from a different perspective, and that is the perspective of being a physician who has spent a good portion of my career, and I still do work in the far north. I can let you see who I am if you like. Then maybe I can. And one of the barriers to accessing care in the north is the distance. And if the specialist to whom we've referred a patient is not going to be remunerated at a reasonable amount, it's far more likely that they are going to continue to ask to have the patients transferred by air at considerable expense to the government and considerable expense, I think, to their proper care. So having a virtual consult is an answer to that problem. I think for most, I believe that it was Dr. Cardoza many years ago who said that he could diagnose 80% of his women's patients' problems by a telephone call. So I think we shouldn't underestimate how much you can do by virtual or by telephone, and or how much energy it actually takes for the physician providing the care to take the time to tie up all the loose ends and leave it as a very good consult. Thanks. I would vote against this, but I actually am not a voting member.
Any other comments?
We have a hand raised from Dr. Groves.
Dr. Groves, please.
Different family physician situations require different ways of addressing this issue, and I wonder if there's a way to reword this resolution to really focus on our ability to work with the ministry for remuneration models for virtual care that are commensurate with the work we're doing, as opposed to just having a blanket statement that virtual care equals in-person care no matter what. And I wonder if that would help resolve some of the issues that are coming up here. Maybe I'll defer to Dr. Pillay and Dr. Mula around whether that would be acceptable to them to make an amendment to basically to work with the ministry to have virtual care consults be remunerated at a level commensurate with the work being done, as opposed to kind of saying it's, it just has to be equal virtual versus in person.
Thanks, Dr. Groves. Any other
We have a
speakers?
hand raised from Dr. Letting.
Dr. Letting, please go ahead. This should be Dr. Letting. Thank you.
All right, I'm not going to vote in favor of this motion as it exists right now, because I don't believe that the quality of the consult is the same. I'm seeing consults that are virtual, and I think they miss things. And I know from my own clinical experience that when that patient is sitting in front of me, I have many more cues than just visual and auditory. And if you're going to assess a patient well, I know that you have to see them in person to pick up the subtleties. I seriously do object to psychiatry getting underpaid, but I also think that psychiatry of all people should know that if you want to evaluate your patient well, many times you have to be hands-on right in front of them and picking up the cues. So I'm against it as it is.
Thank you, Dr. Letting. We'll give a moment for any other hands to be raised. Oh, sorry. There are hands raised here in the room. Can I go to Dr. I'm going to go to Dr. Epp. Would you like to use the stage, Dr. Epp? Then they can see you on video. Dr. Epp.
Hi again. This is clearly a complex issue, and I think it's really great that we're all at this table having this discussion because we each know our own worlds best, and it's good to kind of delve into other people's worlds and see where they're coming from. In terms of the 67%, this exact same thing has happened in obstetrics and gynecology because it's my understanding that the virtual care rates are 90% of our old consult rates from 2020, so they don't reflect the new pay schedule. So when sections put money into their consult fees, virtual care did not get that. So there may be a way to correct this by actually making a motion to make it reflect 90% of what our actual new in-person consult fees are.
Thanks, Dr. Epp.
But Mark Caesar should correct me if I'm wrong.
Thanks, Dr. Epp. Any other questions?
We have a hand raised from Dr. Pillay.
Dr. Pillay, this will be your second time speaking. Please go ahead.
Thank you. Can I just speak again on the motion, Mr. Speaker? Thank you. So I know I hear what my fellow colleagues are saying. I think we need to look at the intent of the motion, and the intent of the motion is not to debate about virtual care and how it's done and how it can help, because we've already done that many times. The issue here is the remuneration for the actual service. I just want you to think about this differently. Imagine somebody on contract position or on a salaried position doing the virtual care. Do they get paid less in their contract or salary for seeing that patient on virtual care? And we have a classic example. We have a large unit here that sees cancer patients, and they see patients on a virtual basis their contract has not changed. So that's just an example. I'm not picking on them. I'm just using that as an example. So if we salaried or contract, do we get paid less for doing virtual care? And this is what I'd like you to keep in mind when you're thinking about voting for this resolution. It's about remunerating for a service that's provided. And I hear that you can see, feel, and touch and learn a lot, but there's a fair amount that goes into providing information for other services on a virtual care platform. And we should be remunerated on an equivalent basis. I don't give my patient any less care when I review that MRI result or lab result. Thank you.
Thanks, Dr. Pillay. Next, please.
We have Dr. Jewett from Saskatoon.
Please go ahead.
Thanks. I just want to address this issue as a new family physician just starting practice. And I started my residency during the pandemic. And so the whole virtual care was a new thing. And what we did, I hope we are all professionals that can judge whether we need to see a patient in person or not. If I look ahead at my day sheet or, down the road, I can say, you know what, I'm going to need to see this person in person. But just because someone has, let's say, something that's fairly simple, you can judge by that often. And you're right, Dr. Mueller, this care is the same. I think you have to rely on your professional judgment. And if I have something on the phone that I think needs to be in person, then I'll just make arrangements for that. But when we talk about retention of physicians, particularly family physicians, you don't have any less overhead, as psychiatry says. You are still providing good patient care if you retain the professional judgment to bring the patient into clinic, but it is a disincentive. It's devaluing some of the services you provide to not at least consider that it should be the same pay as a regular type of a visit.
Thank you. Any other debate? No other debate. So I'm going to read the resolution again. Be it resolved that the Saskatchewan Medical Association advocate the Ministry of Health to have virtual care consults be remunerated at the same rate as in-person care. Delegates, please open your Slido browser. You will have 30 seconds to vote. I would like to open the polling now. Polling has begun. Polling has ended. The votes are opposed to the motion 37, in favor 26, 1 abstention. This motion is defeated. Resolution 18. Be it resolved that the Saskatchewan Medical Association advocate for on-par prices between virtual and in-person psychiatric visits to support a patient-centered approach to mental health relevant services in Saskatchewan. Moved by Dr. Renuka Prasad, seconded by Dr. Cooper. Dr. Renuka Prasad, as mover, would you like to speak to this motion?
Hello. Saskatchewan Psychiatric Association, there is a lot of discussions about the way we are providing the care, and obviously the virtual care is becoming a big tool since the pandemic. And we also felt that many of our psychiatric colleagues who are providing care, particularly in outpatient settings, are using the virtual approach, and it has actually enhanced their access to the patients in remote places and also difficult to reach persons as well. Yes, there are certain individuals who need to be seen in physically, but there are quite a number of services we can provide virtually as well. And we feel very strongly that because of the disparity in terms of the way that it has been, the remuneration has been provided, we feel that virtual and in-person psychiatric visit should be almost in par, so that way we can provide a better service to all the people who need mental health relevant services. I know just preceding this one, we had a good discussions about this care, and we certainly feel that some of the discussions are relevant to this section, this resolution as well. So I certainly hope that Saskatchewan Medical Association advocates at least for on-par prices for both for virtual and in-person psychiatric visits, which is deemed for the betterment of our patients' care, and way we can able to provide it.
Thank you. Is there any debate on this resolution?
We have a raised hand from Dr. Leese from Internal Medicine.
Dr. Leese, please go ahead.
So much. Hopefully you can hear me okay. So as a non-psychiatrist, I just wanted to speak to this resolution. From my perspective, what I have here is a specialty that is telling us that this makes a lot of sense for them. We've heard pleas for help, not just financially, but also to meet the demand that is currently required in Saskatchewan. Furthermore, we all know that mental health is a growing public health concern. It's far outpacing the amount of psychiatrists that we have, and any potential help we can give to expedite their care and create more efficiency in their specialty, I think we should definitely support. So I'm going to be voting for this resolution.
Thank you, Dr. Leese. Next, please.
We have Dr. Bodani next.
Dr. Bodani.
Hi, thank you. Just in follow-up to the last discussion, I should say Dr. Bodani, psychiatrist in Saskatoon, I'd like to speak in favor of this motion as well. And I just want to add that I think psychiatry is unique from other specialties because of the time-based nature of our work. And without debating the quality of the care provided, I would argue that the work of actually providing psychiatric care virtually is just as difficult, or at times even more challenging than in-person care, especially when a person is acutely ill or may require some organization and planning around how to safely manage disposition, etc. As our codes are time-based, we struggled, I think, to understand as a specialty why then the virtual care would be valued much lower than in-person care. And I very much want to thank those who are speaking in support of this motion as well.
Thanks, Dr. Bodani. Next, please.
Next, we have Dr. Garcia.
Dr. Garcia, please go ahead.
So I'd like to speak in favor of this motion as well. Some may know I have relatives who are also psychiatrists as well, and one of the comments that has been made about virtual care in psychiatry is that it does allow even more information than what you could typically get in the clinic, where they actually get a bit of a window into their personal living situations, which can greatly impact some of the decision-making or social networks that need to be added. I think at the very least, at par compensation and further supports for our psychiatry colleagues is, I think, key and in line, and definitely support this motion.
Thank you. Next, please.
Next, we have Dr. Opondo from Public Health.
Dr. Opondo, please go ahead.
Thank you, Mr. Speaker. And I'd like to speak in support of this motion as well, not only by the fact that the specialists are moving this as a way of working, but truly, if we've learned anything in the pandemic, I think there's lots of quality improvement that we can bring in terms of whatever reservations people have, but in terms of access to care, this cannot be argued. This is much more efficient and is an effective way and might actually be the only way. And I would support this motion.
Thank you. Next speaker, please.
Next, we have Dr. Ndibuka, North Central.
Dr. Ndibuka, please go ahead.
Thank you, Mr. Speaker. I'm not completely opposed to the motion, but I just wanted to piggyback on the last resolution that was also talking about virtual care versus in-person. What I did hear one of the speakers say was around the differences in the percentage paid to the psychiatrists compared to the other specialties. So I'm just wondering whether the resolution would probably speak to that in terms of bringing them up to par with the proportion that is being paid to other specialties when it comes to virtual care versus, looking at par with in-person. So just one suggestion I might like to make, if they are open to a friendly amendment, so that we keep the same principle based on what we've discussed in the last resolution. Thank you.
Thank you. Next speaker.
We have Dr. Groves, far northeast.
Dr. Groves, please go ahead.
Thank you. I again just wanted to speak in favor of this resolution, having seen kind of in my own experience as a family physician referring to a psychiatry provider in the far north, where we have tons of problems with access to appropriate mental health resources. The ability for our visiting psychiatrists to provide care to our patients has revolutionized our approach to mental health care and provided huge supports for us as family physicians in supporting patients in community. So I definitely love this resolution.
Thank you. Next speaker.
We have Dr. Thorpe, South Central.
Dr. Thorpe, please go ahead.
I speak in favor of this motion as well. As a family practitioner, I see physical stuff, I see surgical stuff, medical stuff, and psychiatric work as well. And I would say that my ability to reach out to my psychiatric patients who were unable to come into the office or who really just don't like the in-person visit, it has been very helpful. I can see that this would really benefit patients in rural areas who don't have access to psychiatry services. And so I feel this is a different discipline and merits a different view than we did with our last motion. So I would in fact support this motion. And
Next
if nothing
speaker,
else,
please.
I think at minimum, I was going to say at minimum, we should at least bring them up to the, if this doesn't pass, I think we need to then make sure that we bring them up to par with everybody else.
Thank you. Next speaker.
Dr. Pillay.
Dr. Pillay, please go ahead.
Thank you, Mr. Speaker. I'd like to speak for the resolution, and I do believe this is in keeping with my previous resolution in that the virtual consults should be paid and remunerated to full service codes. I would caution that if we are going to go ahead with this, that we should be treating all physicians within our community equally. So we should take it to the next level and look at the patient. Is the patient that we're treating different in psychiatry as opposed to family practice? And do the service that we give as a physician to that patient, is it any different? And if you now look at the remuneration model, why do you need to remunerate one service differently from the other service? I can understand and I get the overhead costs and all the other things that Dr. Salu spoke about, which I support totally. But I think this is creating a difference in care models for the different patient. And it will have a rebound effect in terms of patients being called to the office unnecessarily. Not that I'm going to do it, but it's going to create a rebound effect, and one needs to think carefully about the resolution when we considering this. Thank you.
Thank you. Next speaker.
We have Dr. Sultan next.
Dr. Sultan, please go ahead.
Hi, can you hear me okay?
Yes, we can hear you now. Thank you.
Thank you for the opportunity to speak. I just want to make a comment because I do feel it's a little bit, for lack of better words, and pardon my frankness, but I do find it hypocritical that we're advocating for one specialty to be paid par, but when it came to the last resolution, that was completely opposed. So I don't understand that the, so I support psychiatry, but I support all of my physician colleagues. So I'm having difficulty reconciling the disparity. So I just want to make that comment.
Thank you. There are no other hands raised. So I will repeat the resolution and we'll move to a vote. Be it resolved that the Saskatchewan Medical Association advocate for on-par prices between virtual and in-person psychiatric visits to support a patient-centered approach to mental health relevant services in Saskatchewan. Delegates, please open your Slido browser. You will have 30 seconds to vote. I'd like to open the polling now. Polling has begun. Polling has ended. This motion is carried. Resolution 19. Be it resolved that a new virtual fee code be developed within the sections of internal medicine, dermatology, and pediatrics to acknowledge the complexity and time it takes to manage a chronic disease state. Moved by Dr. Lees, seconded by Dr. Bazin. Dr. Lees, as mover, would you like to speak to this motion?
I was going to give an opportunity to Dr. Basine to speak to it if he wanted instead. But I'm happy to if he's been taken away by.
Sure, we can do that. Please.
Hello. This came from the Internal Medicine Executive meeting, and actually, as the Resolutions Committee, we also amended it to include potentially dermatology and pediatrics as well, because there are a number of specialties that see chronic disease, and in in-person care, these patients often take 15 to 20-minute follow-ups. They have a specific billing code for chronic disease management, and so this is not incorporated into the time and expertise that it takes to deal with these patients in terms of virtual care. And some of these patients can be managed virtually, and so in light of that, we wanted to make sure there was an equivalent or appropriate code so that these patients, that acknowledges these chronic disease patients. So that's the background.
Thank you. Is there any debate on this resolution? There are no hands raised, and so we will, sorry, now there's a hand raised.
We have Dr. Hayton.
Sorry?
We have Dr. Hayton, Saskatoon.
Dr. Hayton, please go ahead.
Hi. So I was hoping one of my family medicine colleagues who has practiced family medicine a lot longer than I have might speak up to this, but I've practiced in a number of different disciplines, and I certainly find that family medicine involves a lot of chronic care. And I'm just not clear on when we start down this road of differential virtual fee code billing, we start to, I to be open, I voted in favor of the last motion because I think psychiatry is a different kettle of fish from my perspective. But I think it's concerning when we start to sort of say that some disciplines, need more payment for care and not others. And I'm not clear on why that wouldn't apply to family medicine, for example. So, but maybe, I don't know if another one of my colleagues who, as I said, has practiced longer than I have might, in this discipline, might want to comment.
Just before we hear from Dr. Basine again, maybe we'll see if there's any other speakers, and then you would speak again. So hang around there. Who's next?
We have Dr. Groves next.
Dr. Groves, please go ahead.
And this is mostly just to Dr. Hayton's point. I think to be clear there, we do have fee codes specific to chronic disease management and family medicine that require, they have some strings attached. And there is a virtual fee code that was constructed during COVID for those specific fees. So, I think that's maybe something with the SME. Like I work on salary, so I fake bill all this stuff, but at the same time, they do exist. So there maybe is some precedent for this.
Thanks, Dr. Groves. Any other people waiting?
We have a hand raised from Dr. Sinha, Saskatoon.
Please go ahead. We're just going to unmute you, Dr. Sinha.
Okay, perfect. Sorry, I couldn't unmute myself. Thank you very much. I am from the section of pediatrics. So just to say that we do have similar codes for patients who are not being seen virtually. So for example, I see bleeding disorders. We can use the complexity code for patients when we're seeing them in person, but we're not able to use them when we're doing the same assessments by virtual. So I think that this is addressing that sometimes we can provide very good care to those patients using virtual fee codes. So I am strongly in favor of this motion.
Thank you. Is there anyone else waiting in line? Yes?
We have Dr. Thorpe, South Central next.
Dr. Thorpe, please go ahead.
Okay, sure. Just to sort of address Sean's comments, the codes that were originally brought in during COVID were actually removed. And so the complexity codes were all gone. They were there during the pandemic, but they were actually removed. So the current status is that there are no codes for counseling. There's a code for counseling, but there's no code for chronic disease management. And there's no time-based code. So all the complexities were removed for virtual care. So I kind of feel the same as what Susan was saying and Dr. Hayton, in terms of we're starting to split hairs and everyone's trying to wiggle their way into better pay for virtual care. It is opening a bit of a can of worms, but I do also understand the concern about the complexity cases, and it does take extra time, and we are being remunerated in the office. Perhaps there shouldn't be a disparity in terms of the complexity cases in virtual.
Thank you. Next speaker.
Next, we have Dr. Letting, Central West.
Dr. Letting, please go ahead.
Yes, I think what we're doing here is we're trying to provide some guidance for our new negotiations coming up. And I perceive a pattern here related to virtual care. And I see a lot of, I guess, in different approaches from different sections. I really think that the bottom line, and I'd like to see something here, is that we need to address all the inequities in the virtual fees so that people are paid on par at some level that's close to, if not the same, as for an actual visit. Now, I'm not personally sure that we need 100%, but I think that we should need consistency here. So it's fine to address internal medicine, dermatology, and pediatrics and psychiatry, but we've heard obstetrics say that they're being indiscriminately treated as well. I think we need to draft a motion here that covers the whole piece and creates a direction for the new negotiations.
Yep.
Next, we have Dr. Pillay, Regina.
Dr. Pillay, please go ahead.
Thank you, Mr. Speaker, once again for allowing me to speak on the resolution. Yeah, I hear what Dr. Letting is saying, and I kind of echo his sentiments. We're also creating some discrimination here between sections. We can see the spiral going downwards from the motions. And, to address the immediate motion, I'm going to say I would like to make a friendly amendment and suggest that be it resolved that a new virtual fee code be developed within the SMA to acknowledge the complexity and time it takes to manage a chronic disease state to cover all disciplines, because you're forgetting family practice, you're forgetting all the other little specialities that have complex conditions. Yes.
Dr. Pillay, I hear you proposing an amendment.
Yes.
So I'm just going to ask Dr. Bhasin if he'll just have a seat for a moment, because we're going to do some other business for an indeterminate length of time here. So you're proposing an amendment, and I think I heard it be it resolved that a new virtual fee code be developed within all sections? Is that what you're suggesting? Well, what are you proposing, Dr. Pillay? Can we put Dr. Pillay on again?
Yes, thank you. Within all sections.
So we're taking out specifically internal medicine, dermatology, and pediatrics, and you're putting in all sections. Is that satisfactory to you?
To me, yes.
Okay. So now, everybody, we are working on an amendment to this resolution, and further debate until further notice is discussion about that resolution. And the resolution essentially says, forget about the internal medicine, dermatology, and pediatrics that you see there. It's for all sections. Dr. Pillay, you've proposed that motion. Please speak to it.
The reason, as I mentioned, Mr. Speaker, that this crosses boundaries across all specialties and is not specific for internal medicine, dermatology, and pediatrics.
I apologize. My bad habits are showing again. Is there anyone who would second this amendment? And yes, I see a couple of seconders here, and so Dr. Barb Konstantinovich, let's list her as seconder. Sorry, Dr. Pillay, for interrupting you.
No problem, Mr. Speaker. Thank you. Yeah, once again, I just reiterate that the complexity of consultations goes across specialities, across disciplines, including family practice. And I think that all disciplines should have equal access if we're going to propose such a code. Thank you.
Thank you. If you were in line with your hand up on the Zoom platform and you were speaking to the original resolution, could you lower your hand? If you would like to speak to the amendment, which includes all sections, please raise your hand. So we're debating this amended resolution. Please, who's next?
Next, we have Dr. Leese.
Dr. Leese, please go ahead. Oh, sorry, you put your hand down, Ben, thanks. Anyone else in line?
Next, we have Dr. Basine.
Dr. Basine.
Okay, so just to clarify, the original motion, although I know we're talking about the new one, the original one was not meant to exclude, but this was based on existing codes in this fee schedule where there were chronic disease management codes already for particular specialties. These were the ones identified that were not brought over to virtual fee. So if there is one in surgery that already exists in person, certainly this was not meant to exclude. Our understanding, even when we reviewed this at the resolutions committee, was that family medicine did have such a code virtually already. Now that we've been corrected that that's potentially not the case, then I would certainly support that all disciplines that have an existing chronic disease code in in-person care get that moved into virtual or support that motion. So I just wanted to clarify that.
Thanks, Doctor. Thanks, Dr. Basine. Next, please.
Next, we have Dr. Bone.
Please go ahead.
Thank you. I just want to say that in other jurisdictions, can you hear me? Yeah. In other jurisdictions, the complexity is built into the codes, all the fee codes. So if you see a complex patient and you document complexity in your exam, you're reimbursed at a different level. And I think this motion brings up a whole issue that we need to address as SMA and our negotiating committee with the fee structure generally, not just with virtual codes, but with everything. I don't want to broaden the motion, and I'm not going to speak in for or against the motion. I just want to recognize that complexity is something that we really need to focus on in terms of the amount of time we spend with patients. Thank you.
Thank you. Would anyone else like to speak to the proposed amendment?
We have a hand raised from Dr. Parvez.
Dr. Parvez, please go ahead.
Thank
Thank you so much. My question is that who will going to decide? I'm completely supportive of the motion, but who is going to decide the complexity status of the patient? And I am talking about intensive care myself. My every single patient is a complex patient, and we belong to neurology and this and that. So any specialty, any physician can decide that this is a complex patient and I'm going to put a different key code, or there is some sort of jurisdiction, some third party who's going to decide. Thank you.
Thank you. Would anyone like to speak to the amendment to this resolution? There are no hands raised, so we will now vote on the proposed amendment proposed by Dr. Pillay, and the amendment essentially takes out the internal medicine, dermatology, and pediatrics and includes all sections. So, delegates, please open your Slido browser. We are voting on the amendment to include all sections. Please open your Slido browser. You will have 30 seconds to vote. I'd like to open the voting now. The polling has begun. Polling has ended. 50 in favor, 10 opposed, 3 abstentions. The amendment is carried. We will now continue debate on the amended motion. The amended motion essentially says all sections. Is there anyone who would like to speak to this amended motion? Who's next?
We have a hand raised from Dr. Leese.
Dr. Leese, please go ahead.
Thanks. I just wanted to say I think that's a great amendment. When Dr. Basine and I, well, it was mostly Dr. Basine's initiative to craft this. It was intended to be a chronic code to meet the needs of multiple sections, and we were very glad that it meets the needs of multiple sections. So I think that this is a better version of the resolution than what we had come up with, and I hope that everyone agrees that we should move it forward.
Would anyone else like to speak to this amended motion? There are no hands raised. So I'm going to read the amended motion. Be it resolved that a new virtual, no, you don't have to change the mover and seconder. No. Once it's moved and seconded, it belongs to the floor. Be it resolved that a new virtual fee code be developed with all sections to acknowledge the complexity and time it takes to manage a chronic disease state. Delegates, please open your Slido browser. You will have 30 seconds to vote. I'd like to open the polling now. Polling has begun. Polling has ended. This motion is carried. The next item on our agenda at this time is elections, and we will move to elections now. But before we can move to elections, there are still several outstanding resolutions. There are 8 outstanding resolutions. So there's a couple of things we can do. We do have a full agenda up until 4 o'clock, and that is the scheduled time to finish this meeting. I would entertain a motion from the floor to extend the time of the meeting so that we can deal with these other important resolutions. And if any delegates would like to bring that motion forward, I have wording that may be suitable for you. I'll just read it out to help you if you do decide that you want to bring forward such a motion to extend the time after 4 o'clock. For example, you may wish to say, "Be it resolved that the 2022 Spring Representative Assembly of the Saskatchewan Medical Association be extended to consider submitted resolutions." And you may wish to be specific. You may wish to say until 5 o'clock. You may wish to say indefinitely. I have a sleeping bag in my car. I'm here all night. So whatever you think is good. So if anyone would like to make that motion, because alternatively, I believe we then, if we don't deal with the resolutions, Bonnie, then we're bringing back the RA for a special session. Essentially, I'm going to keep you after school anyway.
Yes, that's what was passed, a special session. It was principally focused on the special committee on governance. So,
Okay, so that's, I put that out to you.
yeah, so the resolutions that do not get tabled at this meeting do get referred to the board.
Resolutions that aren't dealt with at this meeting do get referred back to the board. Is there anyone who, there is someone online?
We have a hand raised from Dr. Kalra.
Dr. Kalra, please go ahead.
Mr. Speaker, I will be pleased to make that motion which you cited it, and I have no time limit at this particular time because it depends how many resolutions we have. So at this particular time, I'll take the liberty to put it as a motion as it reads in front of you.
Is there anyone who would second that motion made by Dr. Kalra?
We have a hand raised from Dr. Holland-Natty.
Dr. Holland-Natty, thank you. So the resolution before us is, be it, you see it, I just read it, no changes to it. Is there any debate on this motion?
We have a few hands raised. Dr. Kalra, I'm not sure if you wanted to speak again.
Let's go on to the next one. Dr.
Okay.
Kalra can
We have
decide.
Dr. Stoneham.
Dr. Stoneham.
I'm going to speak against the motion. I plan my vote based on things that are provided to me. I have a commitment at 4 o'clock, and as a representative, a member of the Representative Assembly, I expect to follow the agenda. I think it's unfair to people that have made commitments to not then be part of the discussion process. So if you want to have a meeting, it should be at a time when people can organize to attend. Thank you.
Thanks, Dr. Stoneham. Anyone else like to speak to this?
Next, we have Dr. Pillay.
Dr. Pillay? Go ahead, Dr. Pillay.
Thank you once again, Mr. Speaker. I agree with Dr. Stoneham. I believe we have an agenda and we should stick to it. And the fact that we've run out of time reflects on how we have planned for the agenda. And if the remaining resolutions are not assessed, we should defer them to the board. Or we have planned another SMA special agenda governance, etc. We could defer it to that particular meeting. So I would speak against this motion and suggest that we stick to the agenda. Thank you.
Thank you. Is there anyone else waiting to speak?
Yes, we have Dr. Ndibuka.
Dr. Ndibuka, please go ahead.
Thank you, Mr. Speaker. I'd like to speak in favor of the motion. I do recognize that this is a virtual array, so it's really technically difficult, more realistically, to keep to agenda. And we also being mindful and respectful of delegates and their time, but I think we need to apply some flexibility, recognizing that yes, members have submitted the resolution and these are important businesses to them. So if there is consensus, I will propose that we support this motion to accommodate those resolutions that have been submitted. Thank you.
Thank you. Any other speakers?
We have Dr. Letting.
Dr. Letting, please go ahead.
Yes, I'd like to see the motions that we need to consider. And then I could vote a little bit more intelligently, because right now I'm willing to spend the time. I know everybody can, but at the RA, people don't vote and everything anyhow. Sometimes they leave the room. And sometimes it just for good reasons. Can we see the motions? The 7 that are left, is flash them across the screen so we know what kind of things we're missing?
Hold on a second, please. Bonnie, I think you
Yeah.
want to say something about that. Are they in the workroom?
They are in the RA workroom.
They're in the RA workroom for your attention. So we'll let you go to the workroom, take a look at them while we take our next speaker. Who else do we have to speak? Okay.
Sorry, but by the time
Yeah, it may take you a moment. And so we are, can we mute, please? And we are going to go to a vote. So the resolution, as I read before, essentially is that we will extend the meeting to consider submitted resolutions. Delegates, please open your Slido browser. You will have 30 seconds to vote. I'd like to open the polling now. Polling has begun. Polling has ended. In favor, 32, opposed, 27. This motion is carried. Thank you for that discussion. We're going to move on with the elections. Earlier in the meeting, Dr. Konstantinowicz, chair of the nominating committee, presented the slate of nominations as developed by the nominating committee. We will now commence elections. First, 2022-23 President. Nominated Dr. John Jeffrey. Are there any nominations from the floor?
We have one hand. Oh, do not have a hand raised anymore.
Any nominations from the floor? Give me a moment, please. Is that yes or no? No? There are no nominations from the floor. As such, I now declare Dr. John Jeffrey as President of the SMA. Next, Vice President Dr. Annette Epp. Are there any nominations from the floor? Nominations from the floor. None. As such, I declare Dr. Annette Epp as Vice President. Next, Honorary Treasurer Dr. Andre Grobler. Are there any nominations from the floor? Nominations from the floor. There are no nominations from the floor. As such, I now declare Dr. Andre Grobler as the Honorary Treasurer for the SMA Board of Directors. I'm pleased to announce that Drs. Jeffrey, Epp, and Grobler are the 2022-23 officers for the Saskatchewan Medical Association. I would also like to acknowledge Dr. Eben Strydom as a non-elected officer of the SMA Board of Directors. Your 2022-23 Board of Director nominations are Dr. Pamela Arnold, Dr. Geetan Chandran, Dr. Patrick Duffy, Dr. Susan Hayton, Dr. Carla Holinati, Dr. Mohammed Mullah, Dr. Namdi Ndabuka, Dr. Runa Sinha. Are there any nominations for the position of Director of the SMA Board of Directors? We have a nomination. Please, who's speaking?
We had a hand raised by Dr. Donna Lettingham.
Dr. Lettingham, please go ahead.
Thank you. Yeah, I just wanted to nominate Dr. Naeem Parvez, but not necessarily for the Board of Directors, but not for any individual position within it as a Regina candidate.
Finally, okay? Okay.
You're asking to nominate Dr. Parvez to the Board of Directors? That's what we're,
Can we put him on the slate and put it to a vote?
yep, if that's what you're nominating. Thank you.
That is what I'm suggesting.
Thank you. Is there, do you have a seconder?
We have Dr. Trivedi.
And Dr. Parvez accepts the nomination? Dr. Parvez accepts that nomination? Give me a moment, please.
Yes, I can accept the nomination. Thank you.
Okay. Dr. Parvez, is that okay with you?
Yes, I'm okay with you. Thank you so much.
Thank you very much. Any other nominations from the floor?
Dr. Trivedi has his hand raised.
Dr. Trivedi? Dr. Trivedi, do you have a nomination?
Same as Dr. Parvez, please. I'm nominating Dr. Parvez.
Thank you. Are there any other nominations for the Board of Directors? No. We will just need a moment to adjust the polling. Good. So, you can vote for a maximum of 8 directors. So, with this vote, we will need to verify the results when we go to a break to ensure that only delegates have voted. So, you're about to vote on a slate of 8 people for the Board of Directors. You can vote for a maximum of 8 candidates. Delegates, please open your Slido browser. You will have 2 minutes to submit your vote. Okay? Please only pick up to a maximum of 8. I would like to open the polling now. Polling has ended. We will now move to the next positions, and the results will be shared after the break as we need to verify the results. Next is the 2022-23 speaker, Dr. Kishore Visvanathan. And if you weren't here this morning, I'm Kishore. You may have got that from context. Are there any nominations from the floor? Really? No nominations. Here I am. Next, please. Next slide, please. Deputy Speaker, are there any nominations? I think there was. And I'm excited about it. Please go ahead. Who is it?
We have Dr. Holinati.
Dr. Holinati?
Hi. I think I can hear myself, so I'm going to keep talking. I had been talking with Dr. Kinlock earlier, but I'm looking at the list, and I don't know if she's still here. I know she had to pop out to another meeting, but she did say that it was a position that she was willing to be considered for. I'm not sure if she has to be here in the moment to continue to accept that. I have spoken with her, and she did say she was willing to do it earlier in the meeting today.
Hold on a second. We'll mull that over here. But there was also, and I do apologize, the doctor who spoke earlier and mentioned another name. Has that, I don't want to speak for those doctors.
We have a hand raised from Dr. Dossman.
Dr. Dawson? Please go ahead.
I was just going to second the nomination of Dr. Kinlock if that's allowed.
Thank you. While we are thinking about that, I think we'll go on to the next nomination, which I realize may unduly complicate things, but let's go on to the nominating committee, please. The nominating committee at the moment consists of Dr. Sarah Miller, Dr. Naeem Parvez, and a vacant spot. Are there any nominations? Are there any nominations for the nominating committee? I don't see any nominations, and as such, we will be reposting this position before the fall RA. So if you are interested, please watch for the call for applications coming this summer. I declare Dr. Sarah Miller and Naeem Parvez as members of the 2022-23 nominating committee. What was our final decision on people needing to be present?
We have a hand raised from Dr. Zarabitsky.
Dr. Zarabitsky, thank you.
Yeah, that was on the previous one. Sorry, guys. I couldn't find this hand. Not gonna very easy. But we put Dr. Calder also on the vice speaker position, I think.
Thank you. And I've been corrected that I was wrong about the need for a seconder for a nomination. So we just need the nomination. So thank you very much, Dr. Zarabitsky. Dr. Calvera, can you tell us that that's okay with you? So maybe we'll put that name on the list just while we're getting confirmation from Dr. Calvera that he's okay with that. Thanks, Dr. Calvera.
Yes.
Thank you. I think that this is not a critical election right this moment, And so because we have the CMA president joining us at 14:50, and I think it is time to take a break. We are going to take a break now. We'll do a little bit of homework. Oh, there's someone else
We have a
calling
ha-
in, please.
We have a hand raised from Dr. Hollanati.
Dr. Hollanati?
I was just going to update that I was able to get a hold of Dr. Kinlock, and she popped out of the other meeting and is present now.
Dr. Kinlock is present?
Yes. Yes.
Okay, that's great. So we have Dr. Kinlock, and did she say that she was okay to take this position, or run for this position?
You'll have to unmute her to hear from her, I suppose.
Okay, let's unmute Dr. Kinlock and Dr. Kinlock.
Hi. Thanks, Dr. Holanati. Yes, I accept your nomination.
Thank you. Are there any other nominations? This is exciting. We have 2 nominations for Deputy Speaker. We have Dr. Kalra and Dr. Kinlock. So, would either of, because we're having this election, would either of the candidates like to speak to why they would like to have this position? We'll start with Dr. Kalra. What would you like to say to the delegates? You have 2 minutes.
Thank you, Mr. Speaker. Thank you, Mr. Speaker. It's a privilege to be nominated for the Deputy Speaker position with the SMA. Just to bring my point forward and to address our community, that I've been very much interested in the work of SMA, and I have to let you know that I've been involved in various committees and various other work, including, just to start with, I'm a graduate from Memorial University of Newfoundland, followed by my residency in Ottawa, and moved forward then to Saskatchewan. I've been in Saskatoon for the last 35 years plus, and I've the privilege to serve on various committees, including with the Royal University Hospital, MAC, and also the Legislative Committee of SMA, Health Policy Committee, and Economics Committee of CMA, and also involved at this particular time, and I'm finishing my term on the Board of Governors of the University of Saskatchewan in this June. It will be my privilege to serve along with Dr. Vishwanathan on the side to serve the community as a Vice Deputy Speaker of the SMA. Thank you.
Thank you, Dr. Kalra. Dr. Kinlock, you have 2 minutes.
Thank you, Mr. Speaker. Thank you, Dr. Speaker. So it is really a privilege to be here nominated with one of my colleagues. So not only do you have 2 nominations for Deputy Speaker, but they're both from lab medicine. So that's amazing in and of itself. So for those of you who don't know me, I'm a pathologist in Saskatoon. I have been here since 2008, doing my residency here, and then started here as a staff pathologist in 2015. I sit as the Saskatoon Medical Staff Association president for this year, and would like to be more involved with the SMA at a provincial level. And this seems like that would be a natural progression, and to be under the learned advisory of Dr. Viswanathan. So thank you very much for the consideration, and regardless of the way that this goes, you're going to have a fantastic deputy speaker for the SMA.
Thank you, Dr. Kinlock. So we will go to the vote. Delegates, please open your Slido browser. You will have, can we put up the 30 or the 20? They don't need 2 minutes. Thank you. You'll have 30 seconds to vote. I would like to open the polling now. Hold on, we're not quite ready yet. You have no idea how much running late is killing me. My anesthesiologist wants to go home right now. Ready to go? Let's open the polling now, please. You have 30 seconds and polling has begun. Polling has finished. I declare Dr. Mary Kinloch as Deputy Speaker to the Representative Assembly for 2022-2023. Thank you to both of those candidates. We will now take a break. The CMA President will be joining us at 14:50 at 10 to 3. So sorry for the short break. You can make a 5-minute dash around the block, and we'll see you back at 14:50. Welcome back. We will now bring the Representative Assembly back to order. We'll announce the successful nominees of the Board of Directors after we have our special guest and recognize some special SMA members. It's now our pleasure to welcome Dr. Catherine Smart, President of the Canadian Medical Association. Dr. Strydom, would you please introduce Dr. Smart?
Thank you, for sure. It is now my pleasure to introduce Dr. Catherine Smart, somebody who probably doesn't need that much introduction in Saskatchewan. Dr. Catherine Smart is a pediatrician in Whitehorse, Yukon. She's the 10th woman to be president of the Canadian Medical Association in its 154-year history. Dr. Smart was raised in Swift Current and has strong ties to Saskatchewan. She has a cemented reputation as a trusted, authoritative voice to advance key priorities for Canadian physicians and the medical profession. Her presidency has been underscored by some of the most difficult challenges healthcare workers have ever faced in Canada. She works primarily with children who have experienced trauma and adverse childhood events, and she witnesses the broad and lasting impact these events have on children and their development daily. Welcome, Dr. Smart.
Thank you very much. And my apologies for your short break because of me, so I'm sorry for that. It's really wonderful to be with all of you tonight. Before I begin my remarks, I'd like to acknowledge that today I'm speaking to you from Toronto, the traditional territory of the Wendat, the Anishinaabe, the Haudenosaunee, Métis, and the Mississaugas of the Credit First Nation. And I make this land acknowledgement with the recognition it must come with action towards real change that honors Indigenous peoples as the caretakers of this land we now call Canada. Thank you so much for the opportunity to speak to you tonight about some of the work that's going on at CMA to support physicians and medical learners in Saskatchewan and across the country. Next slide, please. We recognize that the events of the last 2 years have really driven home the need for us to do more in our advocacy and the scope of our work. The pandemic has laid bare devastating gaps in the healthcare system, but it's also provided what we see as a once-in-a-generation opportunity to create change. At the CMA, we think about driving this change, and we are guided by the following vision. We want sustainable, accessible health systems where patients are partners in care. We want communities where everyone has the chance to be healthy. We want a new culture of medicine that embraces equity and diversity and sustains physicians as people, not only as professionals. Throughout this work, we're guided by 6 principles: engagement, accountability, transparency, impact, equity, and diversity. If we are to succeed, we must stay true to these values. If we are to build a just and equitable future for the profession and for our patients, we need diversity of thought and experience at the board and on our committees. We need to build a bigger tent and engage grassroots physicians of all stripes in our work. We need to reaffirm our commitment to reconciliation and take action to dismantle systemic racism and structural inequalities within the healthcare system itself and in the medical community. We need to hold ourselves and others accountable to our commitments. In short, we're working towards becoming a stronger, more relevant, more inclusive organization. Next slide, please. In my role as president, I've been very grateful to be part of this work, to share the physician experience and our knowledge, and to put pressure on governments to act in the interest of the profession and patients. I want to take this opportunity to thank all of you and commend you in Saskatchewan for speaking out for patients and one another during this extremely challenging time, all while navigating a tricky relationship with your government. It's not easy. Thank you for the support you've shown the CMA's advocacy and for always staying centered on what's best for patients and for each other. While we continue to urge Canadians to remain vigilant against COVID-19 as public measures, health measures lift across the country and cases are spiking in certain regions, we also continue to call for action to strengthen the healthcare system, including the health workforce. Next slide, please. New data from the CMA's most recent National Physician Health Survey has shown us just how profound the consequence of the pandemic has been on the country's health workforce. It's unfortunately no surprise that we're now seeing record high levels of burnout amongst physicians, more than twice what we were seeing pre-pandemic. We're also seeing physicians tell us they plan to step back from their clinical work and take time to recover. Our survey showed us that almost half of physicians are planning to reduce their clinical hours in the next 2 years. I've recently seen work by the SMA that has really shown the same thing, and I think it's just a reminder to us about the importance of wellness, and it's helping us also to better understand how the pandemic has affected physicians from across the country. Next slide, please. We've also unfortunately seen a huge rise in misinformation and in personal attacks, threats, and harassment towards healthcare workers. We felt we had a big win in January when Bill C-3 was passed and came into effect, which made it a criminal offense to intimidate, harass, or threaten healthcare workers in person and online. I'm proud of the role CMA played in making this happen and how it will protect physicians and other healthcare workers. While we continue to support physicians at the individual level with our advocacy, resources, and support, we also recognize the need for broader cultural and systems change to address the crisis we're seeing across the system and with the health workforce itself. Next slide, please. We recognize that informed solutions will depend on broad input, inclusive dialogue, and significant action. Earlier this spring, we hosted a Human Health Resource Summit in partnership with the Canadian Nurses Association to hear from representatives from health and social organizations from across the country on the actions that are needed now. Top of the list was creating a robust data source of human health resources and implementing a multidisciplinary nationwide health human resource strategy. We're seizing opportunities to be leaders and influencers in this space, for example, sharing these solutions with the federal government and underscoring the need for them to develop a pan-Canadian health workforce plan in collaboration with all levels of government. We also continue to bring together physicians, patients, policymakers, and others for broad discussions on how to do health differently through our Health Summit series. 2 sessions this month will focus on how to create a health system that's an engine for economic growth. And the final session in June will explore how to rebuild the health workforce. Please visit cmahealthsummit.ca for more information and to register. Physician engagement is incredibly important as we work towards solutions in these and many other areas. So I hope to see you there and hear your voices. I think there's never been more need for physician leadership and for our voices to be heard than what we find today. Next slide, please. Another form of support we're showing for physicians during this time is through funding to provincial and territorial medical associations, including the SMA. Next slide, please. For example, through the CMA's affinity agreement with Scotiabank and MD Financial Management, the SMA received $1 million in funding to support physician wellness initiatives over a 4-year period starting in 2020. The CMA Foundation has contributed more than $860,000 to support various Saskatchewan medical schools, municipalities, community hospitals, long-term care facilities, and frontline physicians and other medical professionals. Through the CMA PTMA Memorandum of Understanding, SMA is receiving $300,000 over 3 years for physician leadership development. This MOU is also providing funding for a health policy research collaborative that will benefit all provincial and territorial medical associations. The CMA has a sponsorship agreement worth $37,500 with SMA and the University of Saskatchewan for a 3-year pilot to deliver an Indigenous sensitivity training cultural awareness course to 4th-year medical students. Next slide, please. Having served at both the territorial level and now at the CMA level, I have a new appreciation of the relationship between the national and the PTMAs, especially through the pandemic. And I think that relationship is of critical importance, and it will really be behind the work we do as we drive forward together towards health system transformation. I certainly understand the many challenges that smaller associations like the SMA and us in the Yukon face. And at the same time, I see the tremendous benefit we get from connecting to share our concerns and work together and learn from each other regarding what the solutions might be. I look forward to continuing the conversation with your new president, Dr. Jeffrey, and I would like to take this opportunity to thank Dr. Claire Kozrowski for her continued work on the CMA board. Next slide, please. Thank you so much for having me tonight, and I'm looking forward to our next piece, which is the CMA Honorary Membership Awards. Am I able to go straight into that, or did you guys have something in between?
I wonder, Dr. Smart, could we see if there's any questions?
Yes, please.
Thank you very much, and thank you for joining us, and thank you for that address, and thank you for your work as CMA president. Are there any questions? If you would like to ask Dr. Smart a question, please raise your hand in the Zoom virtual room.
There are no questions at this time.
Thank you. I think, Dr. Smart, people are excited to celebrate the CMA honorary members, so let's go ahead with that, please.
Okay, wonderful. Thank you. It's now my pleasure to award this year's CMA honorary memberships. I'll be recognizing 4 individuals who've distinguished themselves throughout their career by their attainments in medicine, science, or the humanities, or by significant service to the association. So we will go in alphabetical order. The first recipient is Dr. Bruce Burchide. Dr. Burchide received his medical degree from the University of Saskatchewan and is now retired after working as an interventional radiologist for more than 30 years at St. Paul's Hospital. During that time, he was active in the St. Paul's community, serving on its local council, the Emmanuel Health Board of Directors, and the Hospital Foundation Board. He was also involved with the SMA, recently retiring from its insurance committee after 23 years as chair. He also served on the SMA board from 1989 to 1994 and on the board of the Canadian Association of Radiologists. In his retirement, he hopes to remain involved in healthcare in different roles and looks forward to traveling more with his wife Barbara, a longtime St. Paul's Foundation board member and a palliative care volunteer. Congratulations, Dr. Burchide. The second CMA honorary membership goes to Dr. Jamie Harris. Dr. Harris obtained both a BA in history and his medical degree from the University of Saskatchewan. He practiced family medicine for 2 years in Kindersley before moving to Prince Albert in 1983. He served on the SMA board from 1986 to 1992, represented the SMA in negotiations with the Ministry of Health, and served a term as a member of the Joint Medical Professional Review Committee. He's a medical advisor to the Prince Albert Grand Council on a project to develop an Aboriginal-based medical clinic in the region using the patient medical home model. Since 2009, he's written and published 3 books that combine his interest in history and his passion for golf. Congratulations, Dr. Harris. The third CMA honorary membership goes to Dr. Jeffrey McCarroll. A 1982 graduate of the University of Saskatchewan Medical College, Dr. McCarroll joined the surgical department in 1988. He continues to serve as a professor of surgery in orthopedics and also held the role of chief of orthopedics for Saskatoon City Hospital and the Health Region. His interests include reconstructive orthopedics, sports medicine, arthroscopy, and trauma. Throughout his career, he's been heavily involved in a range of orthopedic and medical groups and national and provincial professional associations. This includes memberships in numerous SMA and health region committees, plus work with the CMA and City Hospital Foundation Board. And most importantly, he lived down the street from me in Swift Current, Saskatchewan. I used to visit his home regularly as a child, and he operated on my mom and fixed her ankle. So thank you, Dr. McCarroll, and congratulations on your honorary membership. Last but not least, the fourth and final member to receive a CMA honorary membership is Dr. Sandra Worth. Dr. Worth retired in 2014, 35 years after graduating from Queen's University Medical School. Following internship and anesthesia training in Winnipeg, she spent 2 years doing locums in rural Saskatchewan and Prince Albert. In 1983, she joined the Rostern Medical Clinic, where she provided full-scope general practice, including clinic work, obstetrics, anesthesia, inpatient and ER hospital coverage. She also commuted to Humboldt for several years to provide anesthetic services before joining the SMA locum program in 2009. She served on numerous provincial and national bodies, the SMA board, the Medical Compensation Review Committee, and was Saskatchewan's representative on the CMPA Council for 9 years. She looks forward to enjoying her retirement with her 2 children and 6 young grandchildren at Deloronde Lake. Congratulations, Dr. Worth. Congratulations to all 4 individuals. What an incredible example of service to their communities and to the medical profession. Thank you all for your service.
Thank you, Dr. Smart, and congratulations to the award recipients. Dr. Smart, let's carry on with the inaugural installation of the new SMA president, please.
Perfect. So it's now my pleasure to install your new president. Before I do so, I would like to thank and congratulate you, Dr. Stridham, for your leadership and strong advocacy on behalf of the profession over this past very challenging year. It's been a very difficult year for physicians, as we know, and for the public and our patients, and we truly appreciate your dedication. So let's give him a round of applause. Your new president, Dr. John Jeffrey, is a professor of respirology, critical care, and sleep medicine with the College of Medicine. He graduated from the Mayo Medical School in 1991 and followed with fellowships in internal medicine and critical care from the Mayo Clinic and a fellowship in respirology from the University of Manitoba. He joined the faculty at the University of Saskatchewan in 2002, where he was active in collegial governance. He has been our RA delegate for several years and joined the SMA Board of Directors in 2017. He's also been active with the Canadian Thoracic Society and is currently on the board of the Canadian Society for the History of Medicine. Dr. Jeffrey, by virtue of authority vested in me, it is a privilege to install you as president of the Saskatchewan Medical Association. During your term in office, you're charged with representing your colleagues in the province and leading the association, the profession, and the public towards a healthier future. I'll now ask Bonnie Brossart to transfer the chain of office to Dr. Jeffrey. Dr. Jeffrey, congratulations on becoming president of the Saskatchewan Medical Association, and all the best to you in your presidency. Thank you so much.
I would now like to welcome Dr. John Jeffrey, the 56th president of the Saskatchewan Medical Association, president for 2022-23, to give his inaugural address to the Assembly. Dr. Jeffrey.
Thank you, Kishore. Good afternoon, RA delegates and guests. Thank you to Dr. Smart and Stridham, and thank you, Bonnie Brossart, and all the RA delegates. It is quite an honor, and I accept the privilege of being the president of the SMA, and I do so with a sense of humility, but also with a sense of purpose. Our profession needs a strong medical association. Physicians need to have our advocacy efforts strongly presented throughout the province, and I'm ready to undertake that work on behalf of leading the SMA. Today I want to talk especially about resilience and optimism. The pandemic has been a long and difficult time for our province and our profession. The strain on our healthcare system has been immense, and the cost in lives tragic, with over 1,300 deaths in this province alone during the pandemic period. Yet throughout this period, we've seen incredible acts of kindness and caring for each other. I think about the countless hours many physicians have put in. I think about the risks that doctors have taken to deal with patients, putting in many long clinic hours, doing many long days on call in the hospital and weekends working, caring for patients. All of these nights and weekends were important, and you did it because you needed to do that. We needed to have good health care for our patients here in the province. During this pandemic, physicians have been resilient, and despite the pandemic challenges, overall, I think we're all optimistic for the future. COVID is not over, and I need to stress that. We are still in the midst of a pandemic. However, being optimistic, I believe the peak of the pandemic has passed, and we can continue to work together and endure going forward. The famous Antarctic explorer Ernest Shackleton once said that optimism is true moral courage. We have seen resilience and optimism these past couple years, physicians sharing the workload to care for the ill, the frail, and the elderly. Doctors from various disciplines retraining to help with inpatients and critical care. Physicians advocating for mask use, social distancing, as well as vaccinations. There's been tremendous work done by our public health physicians in educating the people of Saskatchewan and shepherding us through the past couple years. I admire them for their vision and perseverance during this time of adversity. As a profession, we have achieved significant milestones in pivoting to virtual care and other adaptations to improve patient health. I want to commend all of you for your service to the people of Saskatchewan, and I applaud your resilience in the face of adversity. However, not everything is bright and beautiful. These accomplishments have come at a cost to physician wellness and relationships. As you may know, there are 4 pillars to the SMA strategic plan. One of those pillars is to improve physician wellness, and another is to strengthen relationships. These are touchstones for caring for physicians and for improving healthcare here in the province. Many of our colleagues are feeling stressed due to preventable morbidity and mortality, challenging workloads and work environments, and longer waiting lists. You've heard earlier today about the SMA survey results, and we know that physicians are tired and many of you are feeling burnt out. The feedback we have received is that reform of primary care is necessary. We need to think about how society compensates physicians. We need to work together on this issue. And who is we? When I say we, it's an array of stakeholders, but primarily the Ministry of Health, the SHA, the College of Medicine, and of course the SMA. We all must collaborate together to optimize patient care and make Saskatchewan a great place to practice medicine. As SMA president, I look forward to working with that goal in mind. It is important to remember that you're not alone. If you're feeling stressed or burnt out, we are a community here in Saskatchewan of over 2,500 physicians, and there is help available. Whether it is the myriad of supports from the Physician Health Program, financial assistance through the Medical Benevolence Society, counseling or assistance, the SMA is there for you. And besides the services the SMA provides directly, SMA leaders and indeed all physicians need to be there for each other. It is time to reconnect and rebuild. We need to reconnect and rebuild our relationships with the people and the government of Saskatchewan. We need to reconnect with our loved ones and friends who we have been separated from during this long period of pandemic. And finally, as physicians, we need to reconnect and rebuild our relationships with each other. In the coming months, with careful attention to public health recommendations, the SMA will begin outreach efforts in all four corners of our great province. Pandemic and weather allowing, hopefully no more snowstorms, the SMA staff and I plan to visit physicians in every MSA to meet and listen to you. We want to hear about your concerns and your ideas for improving health care. As you know, the SMA is a member-based organization and it is driven by your needs and your concerns. What can be done different to help you and to help healthcare here in the province? In closing, I want us to celebrate the resilience and the achievements of these past couple years and to be optimistic looking towards the future. Finally, I really want to thank my family, my mother and father who raised me to value education and knowledge, my wife Regina, who has supported me throughout my career and during my leadership journey, and finally my sons Tristan and Matthew, who are my future. And thank you very much.
I think you're going to present an award.
Yes, and next I would like to present an award of merit. So my first official act, my pleasure is my first official act is to acknowledge the efforts and successes of my predecessor, my colleague, my friend, Dr. Eben Strydom, the SMA's 55th president. I've worked with Dr. Strydom on the board of directors for more than 4 years. Eben is a champion of family medicine, and he believes in the special calling of rural doctors. He speaks to these topics with passion and clarity. Over the past year, Dr. Strydom and the SMA Board of Directors has worked hard throughout this roller coaster ride of the pandemic. Dr. Strydom has steered the SMA through some of the most difficult times of this pandemic. He is soft-spoken, and yet he is committed to doing the right thing. He is never wavering in his protecting of the interests of the profession and improving health for our patients. When he saw that SMA had to comment, he would speak eloquently. When he saw that action was required, he moved quickly and confidently. Dr. Strydom, like so many SMA presidents before him, learned the delicate balancing act of what's required of presidents to be president of such a diverse group of professionals. He dealt with challenges calmly and always saw a reasonable path through the many competing interests and agendas, those of the public, those of SMA members, and of course those of the Ministry of Health and SHA. Dr. Strydom met with the Minister of Health regularly, and he always took those opportunities to speak up for physicians. Dr. Strydom led the SMA during the slow retreat of this pandemic. He's always been quick to point out that we are not at the end yet, and we all need to stress that. We're still in a pandemic. He understood things because he's been in the front lines as a rural family physician, and he witnessed the challenges that many physicians are still confronting. Dr. Strydom is a passionate advocate for rural medicine. His knowledge and efforts has served him well as the SMA president. Eben, you've left a positive mark. He has helped to revitalize the MSAs, and we and the SMA will see the benefits of this revitalization for years to come. Similarly, he was president when the SMA began the work on improving and reviewing the governance structure. Thank you, Eben, for all your hard work. This past year has really made an impact. I would like to ask you all join me in saying thank you to Dr. Eben Strydom for serving so successfully as the 55th president of the SMA. On behalf of the SMA, please express our sincere thank you. Congratulations again, Eben. In concluding, I want to add that the work of the work of any SMA president cannot be done without the support of family. We have a tradition here in the SMA whereby we recognize the importance of the president's family. With that in mind, I want to acknowledge Dr. Strydom's partner, Mariante, who was tremendously supportive of him during the past year, and indeed during his many years on the SMA board of directors. Even also pass on to your children our thanks, your son Okhart and Liam, and thank you so much for your service this past year. And with that, I will thank the RA. It's been a wonderful day, and I hope everybody has a pleasant weekend, and I look forward to seeing you all again soon. Back to you, Kishore.
Thank you. And congratulations, Dr. Jevry. On behalf of the RA, I wish you all the best during your presidency. Thank you. We'll continue on with business. The next item of business is that the election of the Board of Directors has been completed, and we have confirmed that the votes did come from delegates. So please, can we see the poll results? The poll results confirm that the Board of Directors will consist of Dr. Carla Holanati, Dr. Pam Arnold, Dr. Susan Hayton, Dr. Geetan Chandran, Dr. Runa Sinha, Dr. Patrick Duffy, Dr. Namdi Nabuka, and Dr. Mohammed Mullah. Thank you very much to the new Board of Directors. We will now proceed or finish off the discussion of resolutions, and we will take up where we left off, which is resolution number 20. Resolution number 20. Be it resolved that the Saskatchewan Medical Association advocate that no shows for appointments for fee-for-service physicians be billed to the medical service branch at the equivalent consult fee for the appointment. Moved by Dr. Pillay, seconded by Dr. Bazin. Dr. Pillay, as mover, would you like to speak to this motion?
Hello? Hello,
Yes,
can you
we
hear
can.
me?
Go ahead.
Sorry, can you hear me?
We can hear you now. Thank you.
Okay, thank you. So, no shows for appointments in fee-for-service practice is an ongoing concern. Whilst many physicians remain empathic for reasonable no-shows, there remains a significant loss to patient care, delayed care, compromise to other patients, and lastly, an income loss to the practice of clinic for fee-for-service clinics. In an effort to help alleviate some of the financial loss, it will be reasonable to consider a charge for no-show patients. So it is therefore that I propose this resolution that for fee-for-service physicians that no shows for appointments be billed at the equivalent consult fee for the appointment. Thank you.
Thank you. Is there any debate around this motion? Who's first?
We have a hand raised from Dr. Groves.
Dr. Groves, please go ahead.
Yeah, thank you, Kishore. Just a question for those who are putting this motion forward. Would this include an expectation that physicians, fee-for-service physicians who are using this fee code be expected to provide a certain level of service in terms of the way that they schedule their patients and the way that they create their office schedules based on the best available evidence? So I'm thinking of things like advanced access and measuring kind of third next available appointment and looking at capacity. Like, are physicians willing to do that work, or is this just an expectation that if there's a no-show, you get paid?
Thanks, Dr. Groves. So that's a question for Dr. Pillay, but we're going to hold off on that and let Dr. Pillay think about it for a moment if there may be other questions, and then we'll come back as that was specifically addressed to Dr. Pillay about expectations on the consultant about level of service. Are there any other speakers, any other debate on this issue?
Yes, we have a hand raised from Dr. Hayton, Saskatoon.
Dr. Hayton, please go ahead.
Hi, I will vote against this motion, I guess. I think there are lots of reasons why people don't show up for appointments, and I think it's not reasonable to be billing the government for that. I think that, as I think was sort of suggested by Dr. Groves, that there are reasons why people don't show up for appointments or can't get appointments or can't get to appointments that sometimes relate to ourselves and the way we schedule things, but there are many other reasons why people can't show. And I think there's mechanisms to handle that in your practice if there's repeated no-shows from a particular patient. And I guess I'm not sure if we try and bill the government for this, is there going to be some, they're not going to like that. So are they going to come down on the individuals who are not showing up for these appointments? And it's a complex situation. So I don't really, apart from just the sort of remuneration side of it, which I can anticipate people want money for these missed appointments, but it just doesn't seem reasonable to me. Thanks.
Thank you, Dr. Hayton. Any other speakers to this motion?
There are no more speakers at this. Oh, we have a hand raised just now from Dr. Sivertson.
Dr. Sivertson, please go ahead.
Hi, I'm not a delegate. May I address the RA?
Yes, please do.
I would have to speak against this motion as well. I do worry that all of the other points that have been raised, and that there would be potentially some glitches within some offices that may occasionally lead to higher no-show rates than others. And I also know that the ministry occasionally will do audits to confirm that patients have attended appointments at certain times to confirm that billing is being done accurately. And I'm not sure how we would prove that an appointment was made and missed and is appropriately paid.
Thank you, Dr. Sivertson. Are there any other questions?
Next, we have Dr. Brown, South Central.
Dr. Brown, please go ahead.
Hi, thanks. Mark Brown from Moose Jaw. Yeah, I think I'd have trouble too, because there'd need to be safeguards here to make sure that, you know, there'd been adequate attempts made to make sure that you confirm the appointment, et cetera, et cetera. The other thing that we need to remember is that even although many of us don't do it, and I'm responsible, one of those people, we are actually entitled to communicate to patients, you know, that they've missed an appointment, and if threaten to bill them for your time privately. So that is allowed by the college, and I think that that's your kind of fail-safe to, if you get a repeat offender or somebody who just is doing this over and over again, that you do have that recourse. I'd have difficulty justifying it as a physician, though, so I wouldn't support the motion.
Thank you, Dr. Brown. Are there any other speakers waiting? Dr. Pillay, there was a specific question. You could address that, or if you'd like to speak further to the motion, would you like to speak again?
Yes, thank you, Mr. Speaker. I hope I heard the question correctly from Dr. Groves and the other speakers. Yeah, I knew this would raise some controversy. We have mechanisms to send letters to patients and tell them you've missed an appointment. So, you know, there's a private fee of $50, $70, whatever it is. I know lots of my colleagues do that. Personally, I never double book patients. So, you know, that's just my personal practice. But the intention of this motion is to allow for those multiple no-shows. And the wording is very specific in the motion. It's not a randomized, well, you didn't show today, you know, we're going to build a government for this. So it's to show for the repeat offender who has no respect for your appointment time, that there is a consequence to this. Now, you know, from personal practice, I've never charged anybody in 20 years for a missed appointment. Although we do send out a little note saying, you know, if you miss your appointment, you're going to be charged an X fee. I was approached once again by one of my family practitioner colleagues with this particular proposal. And that is why I bring this forward. And there are multiple no-shows, even in family practice environment, where there's appointment made for physical examinations, etc. So my intention with this is for the repeat offender who has no valid reason to not show for an appointment. And that's the spirit of the motion. I understand there's lots of discussion to be had about this, and that's fair. I think that we will need to all take time and think about it. And that's what I have to say. If there's any other questions, I can take them.
Dr. Pillay, is there, we have someone else waiting to speak?
Yes, we have Dr. Leese to speak next.
Dr. Leese, please go ahead.
Cool. Thanks for giving me an opportunity to speak. I have looked into this before and done a literature review, and as it turns out, it's very rare that patients are maliciously missing appointments. It actually depends a lot on their socioeconomic status, their access to vehicles, distance from appointment, and also time between the scheduling and the actual appointment. And so I think it's unfair, first of all, to single out frequent no-shows, because in fact, it's more likely there's systemic issues preventing them from getting to their appointments. So for that reason, Dr. Pillay, I'm going to vote against this because I don't think it addresses the core issue, which is that patients can't access their appointments for a variety of reasons.
Thank you, Dr. Leese. Anyone else waiting to speak on this point?
We have Dr. Pillay.
Dr. Pillay, you've spoken twice. We will let you speak again, but hold on. We'll just see if there's anyone else waiting to speak.
There is no one else at this time.
No one else? Dr. Pillay?
We have, sorry, my apologies. We have Dr. Thorpe.
Dr. Thorpe, please go ahead.
I'm going to speak against the motion as it is written. I I just don't think it's the government's responsibility to cover our costs and overheads for no-shows. I just don't think it's appropriate because it is usually the disenfranchised patients that that cause this problem in the first place. But what I have done myself personally is I've used the ability to contact a patient and do virtual care. And so what I have done is picked up the phone, called the patient and said, did you know you missed your appointment? And the majority of the time, patients are remorseful, but I'm still able to help the patient out. And even though I generated the phone call, the original appointment was generated by the patient. And so I have built that as a virtual care visit and have been successful that way. Doesn't work all the time, but at least I am still able to reach out to some of those patients and provide them the care that was needed. A lot of the time it's just they've forgotten or they've missed it.
Thank you, Dr. Thorpe. Is there anyone else waiting to speak?
We just have Dr. Pillay.
Dr. Pillay, this will be your third time speaking on this, so please make it brief and then we'll move to a vote.
Oh, thank you for the privilege, Mr. Speaker. So to address the concerns from Dr. Lees, and Dr. Thorpe, actually, it'll surprise you that it's not necessarily the disenfranchised and the people who cannot afford it to come into your appointments that miss appointments. That's the first point. The second point, I love Dr. Thorpe's suggestion that if a patient misses an appointment, that we call him up and do a virtual consult. So thanks for that suggestion. That's all I have to say. Thank you.
Great, thank you. We'll move to a vote. Delegates, please open your Slido browser. You'll have 30 seconds to vote. I'd like to open the polling now. The polling has begun. Polling has ended. Opposed 52, in favor 3, abstentions 3. This motion is defeated. Resolution 21. Be it resolved that as part of the fee-for-service modernization process, the Saskatchewan Medical Association should consider categories of fee codes or care codes that are procedure-specific and not discipline-specific. For example, wound debridement. Moved by Dr. Pillay, second by Dr. Maslany. Dr. Pillay, as mover, would you like to speak to this motion?
Hello.
Hello?
Yes, thank you. Yes, thank you, Mr. Speaker. The fee-for-service coding system has had systemic concerns with the inability to accommodate for discipline across services. For example, wound debridement codes are in the general surgery category, but can also be performed by other specialties, for example, orthopedics, family practice, or even a rural family practice physician. As part of the fee-for-service modernization process, we should consider cross-categories of fee codes or care codes that are procedure-specific and not discipline-specific. We should look at categories like wound care or counseling, and this should be open to be built by cross-category discipline. So I resolve that as part of the fee-for-service modernization process, we should consider categories of fee codes or care codes that are procedure-specific and not discipline-specific. For example, wound care. Thank you.
Thank you. Is there anyone else who would like to speak to this motions?
There are no hands raised at this time.
Thank you. We will vote on the motion. Delegates, please open your Slido browser. You will have 30 seconds to vote. I'd like to open the polling now. Polling has begun. Polling has ended. This motion is carried. Resolution 22. Be it resolved that the Saskatchewan Medical Association lobby the Ministry of Health to develop a coordinated, comprehensive, multidisciplinary, and evidence-based approach to the management of chronic pain in our province. Moved by Dr. Butt, seconded by Dr. Hollinaty. Dr. Butt, as mover, would you like to speak to this motion?
Yes, thank you very much, Mr. Speaker. As people know, the province has isolated its chronic pain service. Family medicine has chronic pain billing codes, but we lack a province-wide strategy and approach to ensure patients have access to comprehensive, multidisciplinary assessment and treatment. Many become overly dependent on opioids for their pain in the absence of evidence-based and alternative modalities of care. This leads to iatrogenic harms, unnecessary suffering, and decreased productivity. The evidence emphasizes the importance of a multidisciplinary approach to chronic pain. A system of comprehensive consultation and stabilization clinics is required, with increased access to physical therapy and specialized interventions as indicated. Thank you.
Thank you, Dr. Butt. Would anyone else like to speak to this motion?
Yes, we have Dr. Hollinaty.
Dr. Hollinaty, please go ahead.
Hi, thank you so much. I think that this is an issue that's probably near and dear to so many family physicians' hearts. I spend an inordinate amount of time on a lot of days trying to figure out how to get access to the services that patients need to help them deal with their chronic pain. And when I can't, it just means that they keep coming back to see me over and over and over again and taking up a lot of time sort of trying to keep them as stable as we can, but really not getting them that ideal management that they need. And that means that my access to patients who don't have chronic pain becomes worse and worse with every new chronic pain patient that I have. So I think that this is a really critical issue that is really desperately needed in the province. Thank you.
Thank you, Dr. Hollinaty. Any other speakers?
We have Dr. Letting.
Dr. Letting, please go ahead.
It's a constant frustration in the practice trying to address this and obtain access. Sorry about that, because I haven't talked often enough. Anyhow, the biggest problem I found is that we had a proposition that came through that was actually a private proposition. And then I saw comments from the individuals that are doing it within the system who aren't able to keep up. And I was upset with the fact that we got into the issue of private versus public. I would like to see both avenues explored. And in the end, I'd like to see some access because it is really, it's not working as is. Access is terrible.
Thanks, Dr. Letting. Any other speakers? No other speakers? We will vote on this motion. Delegates, please open your Slido browser. You'll have 30 seconds to vote. I'd like to open the polling now. Polling has begun. Polling has ended. This motion is carried. Resolution 23. Be it resolved that the Saskatchewan Medical Association Board of Directors advocate for global COVID-19 vaccine equity by urging the Canadian Medical Association to call on the Government of Canada to support the agreement on Trade-Related Aspects of Intellectual Property Rights, or TRIPS, waiver proposal. Moved by Dr. Khan, seconded by Dr. Opondo. Dr. Khan, as mover, would you like to speak to this motion?
Thank you, Mr. Speaker. I'll defer to Dr. Opondo.
Dr. Opondo?
Oh, thanks. So yeah, I hope everyone can hear me. I have my headphones on. So the background behind this resolution, which has come from the public health section, is we all have witnessed how dramatically COVID-19 vaccines changed the course of the pandemic once it became available. But global vaccine equity remains a real problem. And the fact that some of our global partners in less developed, so low developed and middle developed countries don't have access to vaccine has resulted in some real unevenness, where in April of 2022, about 17% of residents, particularly in the global south, had received 1 or 2 doses of COVID vaccine, compared to global north, where the coverage rate was an average of about 70-something%. So there's a fairness and equity issue. There's an issue of our own protection and our own interest. Omicron did come from a situation where there was poor vaccine coverage. So what this resolution actually speaks to is the SMA board supporting work that has already been done by the CMA board, where they've advocated some parts of this work with the federal government in terms of a larger participation in COVAX, which is the Global Vaccine Fund, and operationalizing vaccines. But the issue of addressing intellectual property and property rights, this is one that has not yet been spoken to. So this is the request, that the SMA board support and work with the CMA board to connect with the federal government to support an agreement which, for the duration of the pandemic as it remains, there will be a waiver or a relaxation of these international, the trade on international.
Your time is finished. Are there any other speakers to this motion?
We have a hand raised from Dr. Keketla.
Sorry?
We have a hand raised from Dr. Keketla.
Dr. Keketla, please go ahead.
Thanks so much. I appreciate the opportunity. I decided to speak in support of this proposed resolution. I think there's a window of opportunity for the Saskatchewan Medical Association to take a leadership role ahead of the next round of the TRIPS Council meeting. There was a discussion, I believe, that happened today, but Canada has still not affirmed their support for this specific proposed waiver. The motion specifically, the proposed resolution specifically speaks to vaccines, although the broader proposed waiver includes other types of products, including treatment, medications, and other types of medical products. So I think this is in alignment with the role that the SMA has in terms of physician leadership. And we also have the double advantage of actually making some little bit of an impact, I think, in terms of global vaccine equity. Thank you.
Thank you. Are there any other speakers?
We have Dr. Ndabuka.
Dr. Ndabuka, please go ahead.
Thank you, Mr. Speaker. I would like to speak in favor of the motion, just recognizing that no one is safe until everyone is safe. The issue of vaccine inequity continues to be a key concern globally, And I think if we take this advantage at the SMA level, working collaboratively with the CMA, that would help to lend the voice in terms of ensuring equitable distribution of vaccines to reach the vulnerable population as well as those that are in low-income countries. So with the advent of new variants and also the uncertainty of where the pandemic is going, I think lending our voice to issues of vaccine equity will be very important in getting us out of the pandemic and for economics to be opening sooner than later. Thank you.
Thank you. Any other speakers? No. We will vote on this motion. Delegates, please open your Slido browser. You will have 30 seconds to vote. I would like to open the polling now. Polling has begun. Polling has ended. This motion is carried. Resolution 24. Be it resolved that as a physician wellness strategy, the Saskatchewan Medical Association advocate the Ministry of Health and the Saskatchewan Health Authority to explore mechanisms which reduce on-call burden on a provincial basis and which may also include providing locum support for specialist groups, especially small sections. Moved by Dr. Pillay, seconded by Dr. Mia. Dr. Pillay, as mover, would you like to speak to this motion?
Sure. Thank you, Mr. Speaker. Physician wellness is an increasingly recognized strategy as per the Impact 2040 statement by the CMA, as well as recognized by the recent survey by the SMA. Physician wellness continues to be a pillar of the priority strategic initiatives. Wellness includes time off clinical duties and a reasonable call system structure. Many physicians think that the burden of excessive call and excessive administrative duties are the leading reasons for burnout and early retirement. This impacts the availability of valued, trained physicians and reduces the healthcare resources. So, I hereby resolve that we should consider as a physician wellness strategy reduce on-call burden on specialist groups, especially small sections. These mechanisms may include provincial distribution of call burden. Thank you.
Thank you, Dr. Pillay. Would anyone else like to speak to this motion?
There are no hands raised at this time.
Thank you.
We have
a speaker?
Some hands raised. We have Dr. Hayton.
Sorry?
Dr. Hayton.
Dr. Hayton, please go ahead.
Hi. From the perspective of wellness for physicians, obviously the SMA is in support of trying to help physicians to manage their practices and not be on excessive amounts of call. And as part of the bylaws, negotiations and bylaws discussions that we have been making an effort to have call kept out of the bylaws, apart from just the fact that you are responsible for your own patients. But we don't want government and the SHA to be involved in our call schedules, in mandating call in any way. And so although we are advocating on behalf of joint responsibility between physicians and government in terms of providing support in all sorts of ways, including appropriate numbers of physicians, appropriate remuneration, and so on. When we start asking the government to get involved in call, I have some concern about that. So just to sort of remind everyone that we are wanting to keep call something that we discuss amongst our own sections, that we try and work out amongst ourselves and not have it foisted upon us in some way. And I know this asks for a decrease in call burden, but as soon as you get government bodies involved in negotiating call and discussing call, and that to me is a concern. So just to put that out there.
Thank you. Anyone else wishing to speak? No, thank you. So we'll vote on this motion. Delegates, please open your Slido browser. You'll have 30 seconds to vote. I'd like to open the polling now. Polling has begun. Polling has ended. Opposed 34, in favor 16. This motion is defeated. Resolution 25. Be it resolved that the Saskatchewan Medical Association advocate the Ministry of Health to engage with and partner with urban family medicine clinics as part of their plan to improve access to urgent medical care and reduce wait times for urban patients. Moved by Dr. Holanati. Seconded by Dr. Dosman. Dr. Holanati, as mover, would you like to speak to the motion?
Hello. So this is a motion that came through the section of family practice that was brought forward by a group of Saskatoon-based physicians who operate some of our larger offices that have walk-in clinics. And I think recognizing that the burden on those clinics is increasing with time and that there are limited supports for them, it's critical for these types of locations to continue working to help keep patients out of the emergency room, because we know that that is already a place that is wildly over capacity at the best of times. And so actually we have one of the representatives from that group who brought it forward, Dr. Sean Clausen, here today, who's not a delegate, but I'm hoping would be allowed to speak to this as well.
Thank you. Do we have any people waiting to speak? Specifically, Dr. Clausen?
We do not have any hands raised at this time.
Any other speakers around this motion?
We have a speaker, or two hands raised. First, Dr. Chandran.
Dr. Chandran, please go ahead.
Thank you. Gitan Chandran, plastic surgeon in Saskatoon. I would like to speak in favor of this motion. I think this is very critically important, and it affects all of us as physicians who practice in this province, because the practical aspect of this is that it's easy for patients to go into an emergency department in Saskatoon or Regina because the proximity. It is much harder for patients who are away outside of Saskatoon or Regina to access care if they really need that care in Saskatoon or Regina. So I think I would be in favor of supporting this, because I think this will help all patients in the province and all of our physicians, including rural physicians who would like to transfer patients to Saskatoon or Regina or a bigger center for further care. Thank you.
Thanks, Dr. Chandran. Any other speakers?
We have Dr. Jewett from Saskatoon.
Hi, Dr. Jewett. Please go ahead.
Thank you. I just wanted to bring a different perspective to this. I'm in a clinic that does have a walk-in service, like, you know, the urgent medical care. And what happened with that is once we started doing it, we actually got penalized because we missed out on one of the ministry payments that is for chronic disease, etc. So when you raise your denominator, and you keep your numerator the same, your percentage goes down. So we actually got penalized for that. And the other thing is that the walk-in patients, there's a huge deficit of family physicians in Saskatoon. What we're seeing for walk-ins is somebody who needs their prescription renewed because they don't have a family doctor, people coming in for very, very, very minor things. But if our walk-ins are full, then some of those people with very minor things will go to emergency. So to me, the main issue is that there aren't enough family physicians, certainly in the urban centers. And so the family practice gets deferred to walk-in, which then in turn gets deferred to emergency. So I don't think this is going to address the problem by trying to do more walk-in. We need to address the lack of family physicians, particularly in urban centers. Thanks.
Thank you. Next speaker, please.
Next, we have Dr. Klassen.
Dr. Clausen, please go ahead.
So I'm speaking as a physician that's practiced family medicine in Saskatoon for 20 years. And for that time, part of my practice is providing several hours a week of urgent care, also known as walk-in, unbooked care, whatever you want to call it. And what I've been noticing in recent years is that clinics like mine that also provide urgent care have been having a greater difficulty year by year retaining physicians and recruiting physicians that are willing to have urgent care as part of their practice. And it's for a variety of reasons, but I can say that we know that the clinics in Saskatoon providing urgent care receive far greater number of patients than SHA and hospital facilities. And we really are a safety net for people that don't have a family doctor or have one and can't access them on an urgent basis. And I know that the speech from the throne in October of last year mentioned plans to build government-owned urgent care facilities in Saskatoon and Regina. And I have to say that I'm really pessimistic that a newly built facility is going to alleviate wait times for patients. I think what we need is physicians that, we do need more family physicians, but I think we also need physicians that are willing to provide some urgent care as part of their practice. And so what I'm really asking for is that we ask the ministry to engage with clinics that provide this care to help with recruitment and retention.
Thank you, Dr. Clausen. Before we move on with addressing this resolution, I just want to acknowledge that some of you are looking at the time and wondering if you're going to stick around because we are extending the time to finish resolutions. After this resolution, there's 2 more resolutions and 1 housekeeping resolution, and then door prizes, and the sense of satisfaction you're going to get from seeing this through is going to be immense. So hang in there. We're going to get this done. Are there any other speakers? Please go ahead.
We have Dr. Kasim, Central East.
Please go ahead.
Yeah, thank you, Mr. Speaker, and the members of the RA. I want to speak in support of this motion, but being a physician in rural area, we are faced with death of family physician too. So I just want to ask the removal of the resolution for a friendly amendment instead of just urban. I think we should just probably say urban and rural patients, because the problem is not just only urban.
Dr. Kasim, I will, if you wish to make an amendment, you can. There's no friendly amendment, but if you wish to make an amendment to this motion, please make your amendment. How would you like to amend it? Sorry, how would you like this amended?
For urban and rural patients.
So if I've heard you right, in the last sentence, you'd like it to read urban and rural patients.
Yes, yes.
Okay. We have a proposed amendment to the resolution. So The discussion will now center around that proposed amendment. So if you had your hand up, please put your hand down unless you would like to discuss the amendment that's just being proposed. First, we need a seconder to Dr. Kasim's proposed amendment. Would anyone like to second the proposal that we add "and urban patients"?
We have a hand raised from Dr. Brown.
Dr. Brown, are you seconding this motion?
No, I'm not. I'm going to hopefully.
Okay, so sorry, I'm looking for a seconder then. Is anyone seconding this motion? If you are, please put your hand up.
We have a hand raised from Dr. Kozrowski.
Dr. Kozrowski, are you seconding this motion?
Yes, I am.
Thank you. Dr. Kasim, as mover of this amendment, would you like to speak to this amendment?
Thank you, Mr. Speaker. Being a physician in rural area, the inability of our patients to access clinics too is very important, so that if this resolution is passed, so it will impact on services being provided in the rural area also to improve access to urgent medical care. Thank you.
Would anyone else like to speak to this amendment? Dr. Brown, did you want to speak to the amendment now that it's been seconded?
Yes, I would like to. Actually, we had a long discussion surrounding this resolution at the section of family practice meeting. And Dr. Hollanadi and I discussed following it, because I was proposing a similar amendment and eventually changed my mind, because this is a very specific ask in an attempt to reduce wait times in the urban emergencies, which can sometimes just be horrendously long. And there is also a commitment in family medicine. There's a working group looking at family medicine in general right now that does make, there is from the ministry a commitment to review everything with respect to family medicine, not just urban but rural. But this is a specific ask surrounding the urgent care clinics in the urban centers. And I think it'll get messy, because if we pass Dr. Kasim's amendment, then what about the regionals, right? So it's going to get really messy. So I would vote against the amendment.
Thank you, Dr. Brown. Is anyone else wanting to speak to the amended motion?
There are no hands raised at this time.
Thank you. So the vote that we're now going to take is on the amended motion. And so the amendment is adding "and rural patients," so urban and rural patients. So at the moment, we are only voting on the amendment, then we'll come back to the main motion. So delegates, please open your Slido browser. You'll have 30 seconds to vote on this amendment. I'd like to open the voting now. Polling has begun. What's happened? Okay, we are going to reset the clock and we're going to restart the voting. Once we have everything, we're going to clear the slate and we'll restart the voting in a moment. Reset. So again, we're voting only on the amendment to add "and rural." So I'd like, are we clearing what I can see? Okay, voting has started. Voting on the amendment is closed. Opposed, 34, in favor, 23. The amendment is defeated. We are now moving back to the main motion. Would anyone else like to speak to this main motion? Yes?
We have Dr. Opondo.
Dr. Opondo, please go ahead.
Hi, Kishore. I think you might have a legacy hand for me. Sorry. Okay. Wait. I think that might be a legacy hand. I'm sorry. I need to put my hand down. So no further contribution to this.
I'm sorry, was that, you didn't want to speak?
Yes. I think.
Correct, he doesn't want to speak. Any other?
We have Dr. Thorpe.
Dr. Thorpe, please go ahead.
I'm not sure whether to for or against it. I'd like to get a bit more clarity from Dr. Holanati. Reason being, the way it's worded is very non-specific, and one of the issues that we're having is we're actually seeing physicians move out of family medicine into walk-in clinics because it's easier and they don't have to worry about patient panels and care, and the money's a lot better in walk-in things in Regina and in Moose Jaw, quite heavily. And so as we're losing family doctors, I kind of have the same concern as Dr. Jewett in terms of we don't have enough family practice docs to actually look after the patients. And it's not just a matter of urgent medical care, it's a case of no medical care. So some of the benign stuff is turning urgent because of lack of care. And not only that, then we're trying to accommodate stuff in the office. And as Dr. Jewett said, a lot of the times it's simple CPAS 4s and 5s that are going to the emergency room to try and get into the doctor's office. So this question, this resolution doesn't really help me decide one way or the other because it's not being very specific.
Dr. Thorpe, you mentioned Dr. Holanati and you're asking for clarification. Is there something particular you want to ask for clarification? What's the question? You have 30 seconds.
Basically, the way it is, okay, let me just rephrase that. The way it is written, I'm going to vote against it because it doesn't really address the problem I see. And I'll just leave it at that.
Thank you. Just in case Dr. Holanati wants to respond, I'll ask her to hold on because that would be her second time speaking. We'll see, we have some other people waiting. Please, who's next?
Next, we have Dr. Jewett.
Dr. Jewett, please go ahead. Hold on a second. This will be your second time around, I believe. Who else do we have?
Next, we have Dr. Letting.
Dr. Letting, please go ahead.
This, but I want to make sure that I understand what it's about, because it looks to me like what we're really trying to say is let's beef up the urgent medical care access. If that's what we're trying to do, I'm in favor of it. Otherwise, it's a little muddy.
Thank you. Any other speakers waiting?
Yes, next we have Dr. Dossman.
Dr. Dossman.
Hello, I'm Dr. John Dosman from Saskatoon, family medicine. I just want to speak in favor of this. I think I agree with some of the concerns that people have brought up about, the root cause of some of these issues being people don't have family doctors or they couldn't get in to see their family doctor on a given day when something semi-urgent has come up, and that, the solution is more family doctors and more resources, but that's not the reality, and that won't be changing anytime super soon. So I think in the meantime that we need to find a way to, keep the stress off the emergency rooms and improve just urgent care in general.
Thanks, Dr. Dossman. Anyone else waiting?
Next, we have Dr. Groves.
Dr. Groves, please go ahead.
Yeah, I do stand in favor of this resolution, but because it's vague, I think Brandon brings up some important points around not the importance of really strong urgent care clinics and urgent care models in all settings, but urban settings in particular, but the importance of engaging with family physicians and the owners of family medicine clinics in how we support access to care for patients. I would much rather see this being about access to the urgent care because I do think there's maybe it's a misinterpretation, but the standalone walk-in clinic is not the solution. And if that's what this is about, walk-in clinics to offer better remunerated walk-in care, I'm not in favor. So I do want some clarification.
Thank you. Anyone else waiting to speak?
We have Dr. Parai.
I'm sorry?
Dr. Parai?
Dr. Prive? I'm sorry if I've got your name wrong. I apologize. Please go ahead.
It's
Go ahead.
Dr. Parai. But anyways, I just wanted to provide some clarification around this conversation. So at the Section of Family Practice meeting, it was brought up that with the recent investment the government announced in the 2 urgent care centers that will be built, like one in Regina, one in Saskatoon, I believe it's a $30 million project in total, 15 to each community, I believe. There was some concern because there are clinics specifically in Saskatoon that do provide urgent care to patients that's in hours outside of their regular family practice. This is not a resolution to try and fix all of the problems of family medicine. We know that there's multiple issues when it comes to that, but this is a resolution that's very targeted at urban urban urgent care, and to see if we can get the government to engage in some of the infrastructure that we already have in place, and if we can get some further funding for the clinics that already offer this service in urban centers. So that is some of the background from the Section of Family Practice meeting. I am absolutely in support of this resolution. I think we should be trying to promote more private-public partnerships if we can, especially for clinics that are run and set up by physicians, because I truly believe that physician leadership and physician-run clinics offer the best care possible for our patients.
Thank you. Are there any other first-time speakers?
There are not.
Dr. Jewett, would you like to speak again?
Yes, thank you. Just a thought with regards to, your patients or individuals not being able to get in that day. What I've started doing, and my patients are quite happy about this, is keeping some spots open during the day for like emergency things. So one that you only can book like a week prior, or another one, and I can open up more that you can only book the day before or that day, so that my own patients don't have to go to walk-in and can see me, especially with walk-in wait times. People are going to cherry pick where there's less wait time. We don't have information sharing, and so that compromises patient care. Family medicine is like one of the pillars is, a patient's medical home. By kind of focusing on the urgent care, and I understand we're not going to fix the shortage of family physicians, but I don't want, because our clinic has it, I don't want to be pushed into doing urgent care. I want to do family medicine. And if I'm going to be pushed in that direction, I'm not really even able to choose part of my career. So I think there's a lot of flaws with this all around. Thank you.
Thank you. We have another first time.
We have Dr. Hollanati.
Dr. Hollanati, can you finish off this discussion? Go ahead, please.
Absolutely, thank you. So quickly, yes, this was brought forward as partially a response to the announcement of the standalone urgent care centers, which I think is what a lot of people are worried about. A place that's not integrated with any sort of comprehensive care at all, pulling people away in some sort of a contracted or salaried method to work only urgent care at a place that doesn't do anything but urgent care. And so what we're asking is that instead of creating an external Frankenstein that's going to drive people away, is that the government instead talk to the family doctors who are already doing this work and are doing it really well and effectively, and engage with them in what the solutions can be that keep these people within family medicine clinics, that are still attaching them to comprehensive care, that are still keeping our family doctors in family medicine. And a lot of the work that the group that brought this forward has done has been about how to make sure that it is valued as being part of comprehensive family medicine and not as a standalone service. So the goal here is to try and find a way to support urgent care as part of family medicine instead of driving it as being a standalone service and pulling people away from family medicine. Thank you.
Thanks, Dr. Holinatti. We'll go to a vote. Delegates, please open your Slido browser. You'll have 30 seconds to vote. I'd like to open the polling now. Polling has begun. Polling has ended. This motion is carried. Resolution 26. Be it resolved that the Saskatchewan Medical Association advocate the Ministry of Health to provide funded access to telephone medical translation services to all community-based physicians in the province. Moved by Dr. Holinatti, seconded by Dr. Dossman. Dr. Holinatti, as mover, would you like to speak to this motion?
Yes, thank you. So this motion came forward after a discussion with colleagues that spend a lot of time working in refugee health. As we see a new wave of Ukrainian immigrants coming to us, they are not going through the regular refugee channels that we would normally see, which is mostly federally funded and through those clinics who have access to things like translation service. Instead, they're being granted really rapid access to Saskatchewan health cards, and that means that they're falling under provincial jurisdiction and seeing people like myself and other family doctors in our clinics rather than being seen through the refugee stream. Now, within SHA facilities, there is a telephone-based translation service that is already available, where you simply just phone in, select the language that you need, and via telephone, you get a medical translator who can help translate things with your patients. What we're asking for is that this be extended to include all physicians within the community who are seeing these patients, so that we don't end up in situations where, you know, I'm having to ask somebody's 6-year-old child to translate for me about their vaginal discharge or their miscarriage or, you know, their spousal abuse. We need to be able to do that in a private and safe way with people who are trained to do medical translations, so that we can provide appropriate and patient-centered, safe care. Thank you.
Thank you. Would anyone like to speak to this motion?
We have Dr. Dossman.
Dr. Dossman, please go ahead.
I don't have much to add that Carla didn't say, other than I've used this translation service, and it's much better than using a family member, where confidentiality could be an issue, or Google Translate or things like that. So I think it's a no-brainer to have access for that.
Thank you. Anyone else? Thank you. We will move to vote. Delegates, please open your Slido browser. You'll have 30 seconds to vote. I'd like to open the polling now. Polling has begun. Polling has ended. This motion is carried. Resolution 27. Be it resolved that the Saskatchewan Medical Association lobby the Saskatchewan Health Authority to establish a medical leadership position for addiction medicine in both mental health and addiction for urban services and primary health care for regional, rural, and remote services. Moved by Dr. Butt, seconded by Dr. Groves. Dr. Butt, as mover, would you like to speak to this motion?
Yes, thank you very much, Mr. Speaker. Peter Butt, Chair of the Section of Addiction Medicine. The SHA, our system of care, and the people of the province would benefit from established addiction medicine leadership positions within the organizational structure of the SHA. Nothing specifically dedicated to addiction medicine is currently in place during a time of record drug overdoses, surging admissions for substance use disorder complications, and inadequate access for services. Effective addiction medicine leadership can have a significant impact on the quality of care, as demonstrated by the medical leadership exercised in the development and operation of the assisted self-isolation shelters during the COVID pandemic. Not only were the most marginalized people served and served well, but a province-wide network of physicians responded and established evidence-based protocols to ensure high-quality care and on-call coverage. We must take the opportunity to use this model to improve addiction services throughout the SHA. Now, in no way should this resolution be construed as a criticism of the SHA's psychiatry leadership. They have more than enough to manage with the pressure on mental health services. Rather, this is hoped to buttress their work on the addiction side and improve the concurrent care interface. I think the comments made by the ministers earlier today were telling. One of the most underserved areas of our healthcare system lacks physician leadership within the SHA. Thank you very much.
Thanks, Dr. Butt. Would anyone like to speak to this motion? No speakers. We will move to a vote. Delegates, please open your Slido browser. You'll have 30 seconds to vote. I'd like to open the polling now. Polling has begun. Polling has ended. This motion carries. As we move on to adjourn, because we had some changes in the schedule today, I'm going to look around the room and I'm going to ask three people if we're okay to finish. Ivan, did we finish all the resolutions except for 28? Tanessa? Bonnie? Great. Before we adjourn, I would now ask for a motion to recognize the efforts of our SMA staff and committees. Resolution 28. Be it resolved that the Representative Assembly thank the committees and the staff of the Saskatchewan Medical Association for their hard work since the last RA. Moved by Dr. Duffy, seconded by Dr. Sinha. Please open your Slido browsers. You'll have 30 seconds to vote. I'd like to open the polling now. Well, we're going to close the polling early. There's no question. So I thank you, and I'd like to add my own thank you to the staff. I get to have a behind-the-scenes look at how much work goes into organizing this. It's an immense amount of work, and I'm so grateful for that. I'd like to remind everyone that our Fall Representative Assembly will be held on October 28th and 29th in Regina at the Delta. As always, the discussion and engagement by members and with the SMA leadership have and always will be instrumental for advancing issues important to the profession. So, between now and then, the SMA looks forward to engaging further with you and the entire profession. We are hoping that we will be in person this fall, and we wish you all a wonderful summer. I now declare the 2022 Spring Representative Assembly adjourned. Bonnie?
Thank you, Kishore. So it is my pleasure to be announcing or to projecting the final door prizes, but we're going to start with the MD financial prizes. But before we show that slide up, we're going to do a brief 30-minute, just kidding, not 30 minutes, it's really short. I just wanted to mess with you, I'm sorry. It's been a long day. Let's see the video from MD Financial, and then we'll put up the slide for the door prize winners. It was only 15 seconds, I think. So there you go. So if we can put up the slide for the winners of the MD Financial door prizes. Congratulations, everyone who is on that slide. We will be sending those door prizes to you next week sometime. Now for the winners of the SMA door prizes. And again, congratulations if you see your name on this list. We will be sending out your door prizes next week. So I will just reiterate, thank you, everyone. Have a great weekend. Be safe, enjoy the spring weather, and celebrate your mothers. It's Mother's Day on Sunday.